Hello guys, welcome to our channel. Today we are going to discuss about the Sureshot series topic 3. In this another 50 plus topics we are going to discuss guys. So from this part 1, part 2, part 3 we have covered 150 plus topics. So as per my previous experiences from the expected topics that I have done almost 50 to 60, and now this time I'm expecting even 60 plus questions also. So if you complete these 3 series and rapid revision videos, yes, this is the very best for your examination, for the upcoming examination. Okay, easily you can score the 150 plus, and with the MCQs practice and with all the PYTs revision, yes, definitely you are going to clear the 200 plus this upcoming effect. So all you have to do is give your best and put your efforts and be consistent until the 17th of January. So okay, so let's start this session through short series topic 3. And first, we are going to complete another some of the important topics from the basic subjects. So first is the cranial fossa. In the cranial fossa, you have to remember what are the foramens that is going to get the cranial nerves and important vessels. Okay, first here you can see this is the cribriform plate. In the cribriform plate, what is the nerve that is coming from? Olfactory nerve that is going to come. Next, here this is the B. So the B, optic canal, optic nerve. And here the third one, C, this is the C. And here suborbital fissure. In the suborbital fissure, you have the three important types. Okay, one is the third cranial nerve, fourth cranial nerve, and sixth cranial nerve. But the fifth cranial nerve, only the first branch is going to come here. Okay, next, superior ophthalmic vein. Next, D, the foramen rodentum. This question has been asked in the PYT. From the foramen rodentum, this one, you are going to get the trigeminal nerve second branch. And foramen ovale, that is going to be trigeminal third branch. Okay, here you can see this is very near to the structures. These three will be going to present. Next, internal acoustic meatus, internal auditory artery, vestibulocochlear, and also the eighth cranial nerve. Okay, facial and the eighth nerve that is going to be come from here. Next, jugular foramen. Here you can see this is the jugular foramen, where internal jugular vein along with that 9, 10, 11 cranial nerves will be passing. Next, hypoglossal, there will be a venous plexus and a 12th cranial nerve, and foramen spinosum, meningeal branch, and also middle meningeal artery. Okay, that is from the foramen spinosum. Okay, this is the foramen spinosum. Next, carotid canal. Here, this one is the carotid canal. J, internal carotid artery. Okay, and coming to the last one, foramen magnum, vertebral artery, spinal vessels, and 11th cranial nerve is going to ascend. That is the differences. Okay, at least remember these important parts, guys. Okay, this can be asked in the examination. Okay. Next, moving on to the diaphragmatic openings. So, in the diaphragmatic openings, there are the three important openings, right? One is here you can see the one is the vena cava foramen, and other one is the esophageal hiatus, and then aortic hiatus. Okay, these three are going to be coming from the diaphragma openings, right? So, in this, you have to remember what are the vertebral levels. So, the vertebral levels here you can see the vena cava is T8, the esophagus T10, and aortic is T12. Okay, next, coming to the structures that is passing is IVC, inferior vena cava, right phrenic nerve. Okay, this is the right phrenic nerve. From the esophagus, vagus nerve, and esophageal of the left gastric artery. In the aortic hiatus, aorta, thoracic duct, and also asgius vein. These are the structures that is going to pass here. Okay, next, here you can see this is the esophagus and a distance from the lower incisor tooth. When you are going to check, this will be helpful for to identify what are the structures that is going to get when you are doing the endoscopy for this patient. So at the length of the 15 centimeters circopharyngeal junction, 23 centimeters arch of aorta, 28 centimeters it will be crossed by the left bronchus, 40 centimeters diaphragma is going to see. Next, here you can see this is the lung helium. In the lung helium, the structure is also important. So in the right side, there will be three lobes, right? Superior, inferior, and a middle lobe. So in this lung helium, you have the four structures. First, bronchus. From the up to down, there will be bronchus and pulmonary artery, and again bronchus and pulmonary vein. Okay, so it is going to be like epiarterial. So above the arterial, epiarterial, and this is the hypoarterial of the bronchus. Okay, this is on the right side of the helium. And next, coming to the left side of the helium, only two lobes, superior and the inferior. In this one, you are going to have the artery first. Okay, then bronchus, and then pulmonary vein. Okay, so the missing structure is the epiarterial branch of the bronchus is not seen on the left side, because that will be covered by this oblique fissure, especially the heart is going to be present this side. The next, tongue innervation. So the first one third of the tongue is came from the arch one. The second two thirds will be coming from the third and fourth pharyngeal arches. Next, coming to the sensation. So here the taste sensation, the first one thirds will be from the seventh cranial nerve, and two thirds will be from the ninth cranial nerve, and third one will be the vagus nerve, that is going to be seen in the innermost, or we can say that is the base of the tongue will be from the vagus. Next, the motor, which will be the sensation. The cranial nerve of the fifth third branch will be supplying for the first one thirds, and again the ninth cranial nerve will be the same for the sensation, motor, and the sensory supply. And also for the base also, vagus is the common. Only difference is he is here the seventh cranial nerve and trigeminal third branch will be seen. Okay, next, moving on to the glomerular filtration. So in the glomerular filtration, you have to see how can we calculate the glomerular filtration. So the first, glomerular hydrostatic pressure. Let's see, this is the glomerular hydrostatic pressure. So what happens? The hydrostatic pressure, that means this is going to be coming from the arterials. Okay, so it is going to come from the arterials towards the Bowman's capsule. Okay, around how much? This is the 55 mmHg. Okay, this is around 55 mmHg. Next, blood colloid. Okay, this is about the blood colloid. So in the blood colloid, so the one blood is going to suck back the fluid. Okay, so from the Bowman's capsule, you are going to send the fluid. Okay, you are going to send the fluid. This is around 30 mmHg. Okay, and remaining capsular hydrostatic pressure. Okay, from the capsule. Okay, from the capsule, you are going to send the remaining fluid. Okay, so this is around 15 mmHg. This is around 15 mmHg. Okay, then how to calculate this? So glomerular filtration, how much we have the glomerular normal GFR, guys? The normal GFR of our body is just around 125 ml, right? So in that we are going to apply the formula with glomerular filtration, glomerular hydrostatic pressure minus Bowman's capsule colloid pressure, and then capsular hydrostatic pressure. Okay, so coming to the value 55 mmHg minus 30 plus 15. So if you subtract this whole, you are going to get the 10 to 20 mmHg. Okay, this is considered as a glomerular filtration normal. Okay, in our patients. Next, coming to the nephron. Nephron is going to have this, particularly the 2 millions of the nephrons will be present. And nephron is important that because it is a structural and functional unit for our kidney. Okay, next we have the filtration barrier, or we can say filtration unit. So it is going to consist of basement. It will be consisting of the basement membrane. So in the basement membrane, this is the one. Okay, and next, along with that, the basement membrane will be covering of the endothelium. And same way, this endothelium opposite to side with the basement membrane, there will be podocytes. Okay, podocytes or visceral epithelium. So here you can see these are the podocytes, and is the endothelium. So this three is going to comprises as a filtration unit, which will be important to maintain the physiological changes in the kidney. Okay, next, moving on to the GI hormones. Okay, GI hormones, there are the multiple GI hormones. At least you have to remember some of the GI hormones which is commonly asked in the examination. First, gastrin. Okay, gastrin, these are came from the G cells, right? from the stomach and the duodenum, you are going to get this G cells. And what is the important function of this one? It is going to increase the H plus secretion. It is going to increase the H plus secretion and also gastric motility. Okay, it is going to maintain the gastric motility. Okay, first one. Next, another one is the somatostatin. Another one is the somatostatin. So the somatostatin is coming from the D cells. Where these D cells are present, guys, especially in the pancreatic islets, it is going to present. So this mechanism is decrease the gastric acid. So it is going to decrease the gastric acid. And along with that, it is also decrease the gallbladder contraction and decrease the insulin and glucagon. In the insulin and glucagon release excess will be also controlled. Next, CCK, cholecystokinin. This is coming from the eye cells, from the duodenum. Okay, and what it will do, it will increase the pancreatic action. It has to increase the pancreatic secretion and also increase the gallbladder contraction. Okay, and decrease the gastric emptying. Decrease the gastric emptying so that the process will be seen. Next, secretin. Okay, the next one is the secretin, which will be coming from the S cells from the duodenum. It will increase the HCO3 production from the pancreas. So the bicarbonate will be produced from the pancreas because of the secretin, and it will decrease the gastric acid. It will decrease the gastric acid and also increases the bile secretion. Okay, so these are the important types of the one of the hormones. Next, we also have the vasoactive intestinal polypeptide. This is like a parasympathetic nervous system. Okay, this is like parasympathetic nervous system activity. Okay, and this is going to increase the water absorption. Okay, the water secretion is going to be present here. Okay, and also the relaxation of the smooth muscles. The relaxation of the smooth muscles is also seen by the vasoactive peptide. Right. Next, we also have the ghrelin. Ghrelin will be important to increase the hungerness. Okay, it will be increases the hungerness in our body. And also we have the leptin. Okay, we also have the leptin. So leptin is like a like which will be important for the fats. Okay, first another thing, this you have to remember, this is the intrinsic factor which will be coming from the parietal cells, right? Which will be coming from the parietal cells. Important for which vitamin, guys? Vitamin B12. Okay, this is also asked question, vitamin B12. Right, these are the some of the important hormones that you have to remember. Next, coming to the chlorination. So in the part of the chlorination, you have to take note what are the important points for the chlorination. Okay, first, what is this one, guys? This is known as a chloroscope. These are the chloroscope, and here we are going to use the some of the important for the checking for the cleanly water in our surroundings. Okay, so how much we need for the drinking water for the chlorination? For the drinking water, you need at least more than 0.5 ppm is important. Okay, next, coming to the outbreaks. So whenever you see outbreaks, you need more than 0.7 ppm. In the pools, swimming pools, it is around more than 1 ppm is required. Okay. Next, chlorination. What is the apparatus that we are going to use? Horrocks apparatus. We are going to use the Horrocks apparatus should be used for this one. But chlorination is not effective. So chlorination is no effect on which type of the organisms. The first one is the hepatitis A and also spore forming organizations, elements. Okay, elements will be also no use. Poliovirus and also protozoa. Also protozoa, also no use of the chlorination. These are the common effects of the chlorination that you are going to see. And what is the chlorinated form we are going to use? Hypochlorous, hypochlorous ions and hypochlorite. Hypochlorite ions are used. Okay, next I want you guys to know about the fluoride also. So how much the fluoride is going to give the effects in our body. So how much is the fluoride levels in the drinking water? Usually less than 0.5 ppm, which will be causing the caries. Okay, dental caries will be seen in the patients. And if it is more than 1.5 ppm, This will be associated with the dental fluorosis. This will be associated with the dental fluorosis, and 3 to 5 ppm, which will be causing the skeletal involvement, early skeletal involvement. Okay, and if it is more than 5 ppm, if it is more than 5 ppm, the crippling will be seen in the patients. Okay, crippling will be seen due to the skeletal involvement. Then what is the normal? So the normal around is 0.7 to 1.2 ppm is normal for the fluoride in the drinking water. Okay, next, moving on to the disaster. So in the disaster, the important points that you have to know, there will be two phases, guys. Every disaster has the two phases. One is the pre-disaster, other one is the post-disaster. Okay, so pre-disaster, we are going to have the preparedness to manage the upcoming crisis. Next, prevention. If you are already seen the droughts or the floods, you have to prevent, right, at least for the future impact. Next, after the post-disaster, there will be a response to save the lives and minimize the immediate impact. Next, recovery from the whatever the causes, either it could be physiological or the psychological. The recovery should be done by the administration. Okay, and disaster will be coming under home. So disaster will be coming under the home ministry. Okay, this will be coming under the home ministry. And what is the most common cause? What is the most common cause of the illness or the disease is seen post disaster? So the post disaster, we are going to see most commonly acute gastroenteritis. Okay, acute gastroenteritis will be seen. Next, most common long term. Long term, you are going to see the malnutrition. Malnutrition is seen. And most common vaccine that should be or arranged for the children, then it is measles vaccine. And malnutrition is seen, measles infection is seen. And what the prophylaxis that we can give for the population? Usually the common prophylaxis will be vitamin A prophylaxis should be given for the people, right? These are the important points about the disaster. Next, amyloidosis. In the amyloidosis also common asked question, what are the types and what are the organs are involved and what specific words we are going to use. So amyloidosis can be is most likely this is due to abnormal, this is due to abnormal protein folding. Okay, abnormal protein folding that is involving in our body. Okay, next, when you see this, you have to understand what are the types. So there will be primary amyloidosis, primary primary amyloidosis. So in that, the most common antibody that you are going to see is the AL. Okay, that is the AL. Next, secondary amyloidosis. So the secondary amyloidosis is AA. This is the AA type, which is more common. This is more common. Secondary type is the more common. Okay. Next, we also have the different types of organs will be involved. First, if it is involved by the heart, then it will be transthyretin. It will be transthyretin, and this is going to be cause the heart condition, and also it is present in the familial type of the amyloidosis, and it can cause the most common cause for the death in the patients of the amyloidosis. Okay, first thing. Next, coming to the organs, which organs are most commonly involved? The most common organ that is involved is the kidney. Okay, kidney is the most common one to involved. So what is the amyloid that will be present here? Beta 2 microglobulin. Beta 2 microglobulin, which will be needed for the dialysis for this patient. Next, brain. Okay, we discussed it just yesterday. Alzheimer patient. So for this patient, you are going to see only one beta amyloid. One beta amyloid will be seen here. Next, type 2 diabetes mellitus patient. So type 2 diabetes mellitus patient, there will be islet amyloid. Islet amyloid is also seen. Medullary thyroid carcinoma patient, there will be calcitonin. Calcitonin types. Next, prion disease, it will be PR. Okay, these are the types of the amyloidosis which will be present. And what is the common stain or the best stain, guys? We are going to use Congo red. Congo red we can use, and also Lugol's iodine. Okay, Lugol's iodine is also seen. Most common site for the biopsy, that is the abdominal aspiration. Abdominal as fat aspiration. This is the common one we are going to use for the amyloidosis biopsy. Next, moving on to the anemia. So in the anemia part, you have to take note what are these parts of the anemia that will be important, what are the cells, how we are going to interpret. So here you can see guys, this is the common picture or the blood plasma blood smear that we are going to see, right? So first here, these are the acanthocytes. These are acanthocytes. So in the acanthocytes, seen in which conditions, such as liver disease patient, we are going to see this one. Okay. Next, these are the echinocytes. These are echinocytes. Echinocytes are seen in the patients, those who are suffering from the end stage renal disease patient. Next, these are the pencil cells, or sorry, these are the teardrop cells, are also known as a dacrocytes, seen in the myelofibrosis. Seen in the myelofibrosis. Next, these are known as a helmet cells. These are known as a helmet cells or the cystocytes seen in the patients of the HELP syndrome, right, in the pregnancy period, or also it can seen in the DIC and autoimmune hemolytic anemia patients also seen. Next, these are classical picture bite cells. Bite cells are seen in the G6PD patient. Next, this one is the sickle cell. This is seen as a sickle cell seen in the sickle cell anemia. Here these are the target cells. Okay, target cells. Target cells are seen in the thalassemia patient, right? Next, these are the macro, like larger type. Macro is seen in the B9 or the B12 deficiency. This is spirocyte. These are the spirocyte. Again, these are seen in the hereditary spirocytosis we are going to see. Next, these are the elliptocytosis. Okay, this kind of the structure which will be seen in the elliptocyte. So this is related to the hereditary elliptocytosis. Okay, hereditary elliptocytosis we are going to see. And another picture here you can see, these are some of the examples guys. So this one is known as a, like commonly these are Howell Jolly bodies. Okay, these are known as a Howell Jolly bodies. Okay, Howell Jolly bodies are seen in the sickle cell anemia patients. Okay, next, this is known as a sideroblastic anemia. These are known as a sideroblastic anemia, like Pappenheimer bodies. Pappenheimer bodies you are going to see. Next, this is the stippling, basophilic stippling. This is the basophilic stippling seen in the lead poisoning. Lead poisoning patient, you are going to see the basil. Next, these are the hens bodies. These are known as a Hens bodies bite cells, commonly seen in the G6PD patient. Okay. Next, coming to the this table, important table, difference between the iron deficiency anemia and the sideroblastic anemia. Basically, iron deficiency anemia, iron ferritin is already decreased and also transthyretin also decreased. So the TIBC, the capacity for the iron carrying is less. So the TIBC value will be increased in the iron deficiency anemia. Sideroblastic anemia, what happens? It is completely opposite to the iron deficiency anemia. So the TIBC will be decreased, but the iron level, ferritin levels and the T% levels is increased. Next, anemia of the chronic disease. You have to remember, if it is not considered to be the IDA or the CSA, then you can go with the anemia of the chronic disease. All right. Next, moving on to the leukemias, important leukemias that you can see. So the first features of the AML and the ALL. AML is commonly seen in the adults, ALL is commonly seen in the children. So the myeloid is going to be positive for the myeloperoxidase, and in this picture also, and the pathognomic sign is the R bodies, and commonly it will be associated with the major complications like DIC, and myeloid is going to include the only the central portion. Okay, next, coming to the ALL, seen commonly in the children, and it is going to cause the lymphoid, and what is the positive here guys? TDTA. So the translocation T12 and 21 is going to show the good prognosis. Lymphoid is going to include the central or the peripheral type. So peripheral like testicular and also CNS involvement will be seen. But ALL has a better prognosis. Next, CML and the CLL. For the patients of the CML, it is going to be middle-aged adults. Myeloid will be the positive, and translocation like 922 Philadelphia chromosome and also BCR-ABL will be the key mutation. And on that, you are going to see the blast crisis. The blast crisis which will be related to the commonly the related blast cells in these patients will be due to basophils. Okay, next the imatinib will be given as a treatment protocol. CLL, the patient mostly elderly, you are going to see the smudge cells, and CD5 CD20 B cells will be the positive, and Richard transformation, like it can also trigger and can form the lymphoid leukemia, like the chronic leukemia will be also transformation will be seen in the patients of the CLL. Next, coming to the Hodgkin lymphoma types, there are multiple types of the Hodgkin lymphomas, and the most common in India is the MCHL. Okay, and you are going to see the Redstone-Berg cells. So the Redstone-Berg cells are many types, but the classical type will be seen in the lacunar type of the. This is the another type of the lymphoid rich Hodgkin lymphoma, guys. This is the classical Redstone-Berg will be seen. Next, coming to the Epstein-Barr virus. Epstein-Barr virus most common in India, which will be associated with this condition. Okay, remaining all very less, like this is the non-large non-lymphocyte leukemia and also other leukemias. The EBV, the Epstein-Barr virus, is less commonly seen. Okay, next coming to the non-Hodgkin type of the lymphomas, you have the three different: marginal cell, mantle zone, and also follicular lymphoma, Burkitt's lymphoma. Okay, these all are the translocations. At least you have to remember Burkitt's lymphoma, c-MYC gene will be important, and also starry sky appearances. Okay, starry sky appearances will be also seen in this patient. This is known as a Hodgkin lymphoma and the non-Hodgkin lymphoma classifications. Next topic we are going to discuss is the epitaxis. Okay, so first, before we understand the epitaxis, let's see what is the nose arterial supply. Okay, so the nose arterial supply will be coming from the two carotid arteries. Okay, one is internal carotid artery and other one is the external carotid artery. So the most of will be coming from the external carotid artery only going to supply, because this one is only going to give the branch to the maxillary artery, and further this maxillary artery is going to give the branch for the sphenopalatine. Okay, this is going to give the sphenopalatine. So this is the major arterial supply for our nose. So coming to the epitaxis is two types. One is commonly seen with the little's area. So this little area is known as a Kesselbeck's. This is known as a Kesselbeck's plexus. Okay. So this is the most common for the patients to get the commonly for the nose picking, or if there is any foreign body, so this is going to cause the bleeding. So these Kesselbeck plexus is going to involve the important arteries that you have to remember. So what are those? First one is the anterior ethmoidal. It is going to consist of the anterior ethmoidal and also sphenopalatine. This is the major one, right? This is the sphenopalatine and greater palatine and superior labial artery. Superior labial artery. So these four are going to be supplied by the Kesselbecks, right? This is the anastomosis that you can see, right? Where it is present, the location is anterior inferior, right? This is present at the anterior inferior septum, commonly seen in the children patients. Okay, next, coming to, if we have seen this patient, the patient is having this condition, like severe bleeding is seen, how can you going to control this? Okay, how we are going to control? First, we are going to use the trotter method. Okay, we are going to use the trotter method. What does mean by the trotter method? You put the pressure with your fingers. You are going to that completely. You are going to press your nose gently and tightly. That way you can stop this method. Okay, that is by the trotter method. Okay, pinch or gently touch nose tightly. Okay, tightly close the both the nostrils. Yes, that, but still the bleeding is not controlled. The bleeding is still seen. Then what we can go is the endoscopy. Okay, nasal endoscopy we can put, and with that, in that you can add the silver nitrate. In that you can add the silver nitrate, which will be used for the cauterization. Even though if it is not controlled and the blood is coming, then do the nasal packing. Okay, completely stuff with the gauze, or you can put the any some packs, that is going to be the nasal packing. This is done for the anterior And even if it is still controlled, then again go for the posterior nasal packing. Posterior nasal packing with the use of the catheters like air balloon you are going to push and then stop. Okay, with the balloon catheter you can do. This is done for the posterior bleeding also we are going to pack it. Then again still is also not controlled. Then what we can go? We can go for the ligation. Ligation process should be done. So how the ligation is going to start? First the ligation is sphenopalatine. First ligation is at the sphenopalatine. Even though it is not controlled, then go for the maxillary. Then we are going to go for the maxillary artery. Even maxillary artery is also not completed. Then external carotid artery should be stopped. Okay. Along with that, anterior and also anterior, we are going to block the anterior ethmoidal artery. Okay, this is how we are going to proceed and ligation should be done. Okay, this is how to control the patient, those who are come from the epitaxis. Okay, next moving on to the another important picture is this is the nasal bleeding, guys. No, this condition is known as a CSF rhinorrhea. Right, this is the CSF rhinorrhea. Most common cause for this patient, again same condition, trauma is seen. Basically that is associated with the anterior cranial fossa fracture that will be going to cause this cribriform plate damage, and the CSF will be coming from this condition, right? So this sign is known as, what is this sign is known as, guys? Halo sign, or which is also known as a target double ring sign. Target double ring sign. So this is the pale, okay, this is the blood. So the differentiation is seen in this halo or the target sign, double ring sign that you are going to see. Next, investigation of the choice. What is the best investigation of the choice is the beta transferrin. Okay, beta transferrin. This is only seen in the CSF fluid. This is the best. Next, radiology wise, if you want to see where this is coming, then HRCT should be done for this patient. Okay, HRCT should be done. Next, what about the treatment? Treatment is conservative. Within the 5 to 7 days, it is conservation treatment is given for this patient. Okay, within the 5 to 7 days, it is going to resolve. Okay, better give the prophylactic antibiotics to prevent that. And if it is still persisting more than 7 days or more than 14 days, if it is still persisting more than 2 weeks at least, then we can go for the endoscopic closure. Endoscopic closure we can go, right? This is the protocol for the CSF rhinorrhea. Next, moving on to the breast pathologies. Okay, so in the breast pathologies you have to understand what are these multiple conditions and related to, from the inflammation to carcinoma, all the conditions of the breast should be noted, guys. First, coming to this picture, here you can see there are the three different structures, and in these three different structures the patient is suffering from the common condition, inflammation, right? The common condition here is the inflammation. What is that? Mastitis, right? Mastitis is the common condition that we are going to see. And if the mastitis is just going to cause the engorgement, right? This is how the abscess formation or the engorgement is seen in this patient. But if it is turned out to be severe condition, then this fulgent mass will be seen, and this mass will be contents of the pus. Okay, whatever the pus, inflammation pus that is came in this structure is going to be formed here. And here the discharge is also going to see the milk containing the nipple, which will be causing the mucin, this pus, all these structures will be coming from here. So this is the another type of the patient, those who are suffering from the condition of the mastitis and also abscesses. Okay, first thing. Next, moving on to the another picture. So this is the condition of the fibroadenoma. Okay, this is the condition of the fibroadenoma you are seeing here. So in the patients, those who are suffering from the fibroadenoma, commonly which patients, guys? The young age. Okay, the young age patients, those who are with the high estrogen, these patients will be associated with this condition. Okay, this is the fibroadenoma. Next, here you can see this is the another condition. This is known as a phylloid tumor. This is known as a phylloid tumor. In this phylloid tumor, what is this histopathology is showing? Classical picture. This is showing the abrasing partner, or we can also say this like a leaf like, right? This is like a leaf like pattern you can see. Okay, Next, important points that you have to take note about the phyllodes tumor. This is a benign condition and also known as a cystosarcoma. This is also known as a cystosarcoma, very rapidly enlarging, and also it can involve the complete chest wall. Veins also can be seen, but less likely to be metastasis will be seen with this condition. What you can do, simple mastectomy for this patient should be done. Next, fibroadenoma, Mickey Mouse like Mickey Mouse appearances on the ultrasound. And if you see that on the benign condition, like for example, if you see this on the in the x-ray, in the mammography you are going to see the popcorn calcification, and simply there is no treatment should be done for this patient. Okay, it can be treated, so the treatment will be easily done, the patient will be recovery also seen, and it by the age itself it is going to be decreased in this patient. Next, coming to the breast carcinoma. In the breast carcinoma, the TNM staging is very important, guys. The TNM staging is important for this patient. First, let's see what is meant by the T1, less than 2 centimeters. T2 is 2 to 5 centimeters. T3, it is more than 5 centimeters that is involved. Next, T4. The T4 means that is likely to be involved the chest wall, skin, and or even it can cause the inflammatory marks that will be seen in this condition. Okay, so here the condition less than 2 centimeters, 2 to 5 centimeters, to more than 5 centimeters. Either it is going to invade the chest wall, skin, and the inflammatory. That is T4. Okay, next, in the T4 only we have the 4A, 4B, 4C. 4B will be causing the skin. Okay, here you can see this is the 4B. 4B you are going to see with the skin involvement. Okay, the ulceration and infiltration that will be seen in the 4B. Next, 4C. 4C is nothing but it's a combination of 4A plus 4B. Okay, next, 4D, this is Paget's. This is going to be Paget's condition. So Paget's condition will be seen here. Next, N nodes. So the PNO, that the nodes are not yet involved. Okay, N1, 1 to 3 lymph nodes is already involved. Next, N2, 4 to 9 lymph nodes are involved in this place. Next, N3, more than 10 lymph nodes is already crossed. Okay, and MO, that is no spread to the metastasis. M1 is metastasis already seen. And what is the most common metastasis seen, guys? Bones is the most common metastasis. Okay, osteolytic, they are going to eat the entire bones, and especially the Batson plexus from the venous system. Batson plexus, it is going to start from the lumbar vertebrae. First, the vertebrae is going to be spread through the Batson's plexus. Okay, and treatment, the breast conservative surgery should be done for this patient, right? And the drug that we are going to, what is the drug? Trastuzumab that we are going to give for this patient. Next, coming to the thyroid conditions. So in the thyroid conditions, you have to understand how we are going to interpret, right? How we are going to interpret this thyroid conditions. First, hypo and the hyperthyroidism. So hyperthyroidism patient, this is most likely due to increased T3 and the T4. But the negative feedback mechanism will show the TSH as decreased one. Next, here hypothyroidism, the TSHs will be increased because hypo, right? The T3, T4 will be decreased. This is due to negative feedback mechanism. Okay, this is the primary types. But when it is comes to the secondary, already the TSH is also raised. Okay, TSH is also raised in this patient. Same as here, the TSH will be sorry, TSH will be decreased here. This is the hypo. TSH will be decreased, and also T3, T4 will be decreased. This is the secondary type. Okay, next, coming to the types, what are the most common types associated with these conditions? So what are the conditions that will be associated here with the hyperthyroidism? Graves disease. Graves disease is the common one that we are going to see, right? So here you are going to see the Graves disease. What are the Graves disease antibodies that is involved, guys? Commonly it is TSH receptor, or the iodine receptors that will be involved. Autoimmune condition. This will be comes under the type 2 hypersensitivity reaction. Okay. Next, hypothyroidism. In the hypothyroidism, the common one is the Hashimoto's, H for Hashimoto's. Hashimoto's thyroiditis is the common that you one that you are going to see. And here involved is the Tg globulin. The Tg globule, thyroglobulin antibodies are formed for this patient. Next, thyroid cancer. Thyroid cancer is subdivided into the many types. Papillary is the most common. Papillary is the most common. Then second most common follicular, and third most common is the medullary, right? Medullary is C. So papillary, which will be having the orphan Annie cells, right? Orphan Annie cells, which will be classically seen. Orphan Annie cells, and along with that, you also remember the Somoma bodies. Somoma bodies will be also seen in this patient. That is papillary thyroid carcinoma. And papillary thyroid carcinoma, which will be only have the metastasis to the lymph nodes. The metastasis will be start from the lymph nodes. That is seen with this condition. Next, follicular carcinoma. This is most likely going to invade the capsule. So it is going to invade the capsule. So from the capsule, it will touch the vascular. So hematogenous will be spreaded by the hematogenous way. Okay. And coming to the medullary, this is actually associated with the amyloid. Just now we see what is the marker, calcitonin. That is a marker that will be seen. And the C cells which will be involved in the medullary carcinoma. And very rarely another type that is known as a anaplastic carcinoma. That is anaplastic carcinoma. Very rare but very severe condition. Okay. Next, this is the goiter. Goiter is seen in the both condition, guys. Hypo and also hyper. Okay. Hypo patients also seen and hyper patients also seen. Okay. That is the goiter. Smooth goiter and the diffuse. If you see the diffuse goiter, this is associated with the Graves and Hashimoto. If you see nodular goiter, that is associated with the toxic type. Okay, it is going to associate with the toxic type. Next, moving on to the thyroid nodules. These are the benign condition. Thyroiditis. Thyroiditis will be associated with the viral infection. Okay, these are the important points of the thyroid condition. Next, moving on to the fractures. So in the fractures, eponyms will be commonly asked. Like we will see the eponyms, and then I will also discuss about the fat embolism syndrome. First, we are going to see the Bennett's or also Rolando types. So what is this Bennett and the Rolando type? This is actually going to involve the thumb. Okay, mainly it is going to involve the thumb. First, Bennett. Okay, Bennett is going to involve the polar first metacarpal base. It is going to involve. Okay. Next, Rolando. This Rolando is same. It is going to involve, but it will be involved in the thumb base fracture. Along with that, it is going to damage the abductor pollicis longus muscle. Okay. It is also going to involve the abductor pollicis longus, and only one fragment in the Bennett, 2 to 3 fragment will be seen. The bone fracture. Okay. Next, this angle is known as a Bohler angle. This is known as a Bohler's angle. Why this Bohler's angle is seen? This is due to this Bohler region, the tarsal bone structure that is fractured. Okay, that is seen in this Bohler's fracture. Next, this is known as a boxer fracture. So boxer fracture, which will be including the fifth metacarpal phalange joint will be involved in this patient. Next, this condition is known as a March fracture or the stress fracture. March or the stress fracture. So the March fracture or the stress fracture, this is due to involvement of the second toe metatarsal phalangeal joint. Okay, next, this is known as a Love fracture or also known as a calcaneal fracture. Next, this is the 90 degrees traction that you are going to see known as a gallows. This is known as a gallows fracture, and this is the Thomas splint. This is Thomas splint for the tibia or the these tibia fibula fractures we are going to use. Okay. Next, this is the knocker blunt. Knocker blunt. This Nagar blender which will be using for the which patient's case? Claw hand, right? Ulnar injury patient we are going to use. Next, this is the scoliosis patient, Boston brace. This is the Boston brace. Next, this is the aeroplane for the patients those who are using the brachial plexus injury. This is due to brachial plexus injury. Next, this is the Taylor brace used for the pod spine. Next here, this is the Milwaukee brace. Milwaukee brace is used for the patients those who are having the spinal vertebrae fractures. Okay, spinal vertebrae fracture. This is the cock up splint used for the radial nerve. Those who are having the wrist drop now, we are going to use the cock up splint. Next, moving on to the another structures, that is the Monteggia fracture. Okay, that is the Monteggia fracture. Monteggia fracture is due to upper one third of the ulna. Here you can see this is the upper one third of the ulna plus proximal ulnar displacement, proximal ulnar junction displacement, which will be seen in this patient of the Monteggia fracture. And Galeazzi fracture is nothing but the reverse type. Okay, this is going to have the fracture of the radius. This is going to have the fracture of the radius and distal displacement. Okay, distal displacement will be seen. Okay, next Colles fracture. Colles fracture is the distal radius fracture and dorsal displacement. Okay, dorsal displacement. Next, Smith fracture is same distal radius fracture, but it is going to be palmar displacement. That is why it is seen as a, this is like this, like a fork, and this is like a spade you are going to see. Next, common question that can be asked in the examination, fat embolism syndrome. Okay, fat embolism syndrome. Fat embolism is most commonly associated with the fracture of the which one, guys? Commonly with the femur. Femur is going to be attached with the fat embolism syndrome, and this is seen in the less than 24 hours from the fracture. The patient will be developing of the sudden rash, and also sudden increase of the tachypnea, and even if it is left untreated, the patient can go into the depression and the coma. Okay, what is the criteria that we are going to use for this one? GERDS criteria. It is consisting of the major and minor. Major, you are going to see the systemic involvement. Minor is we are going to calculate the blood loss and also the length of the femur fracture you are going to see. Next, moving on to the hip dislocations. They are the two important hip dislocations. One is the posterior and other one is the anterior. So in the posterior, anterior, which is the most common, guys? Posterior is the most common one. For this one, you have to remember the fadir. Okay, fadir. So fadir means abnormal movement, flexion you are going to see, and adduction at the thigh region, and internal rotation. So adduction at the thigh, flexion at hip. This is going to see. And how about the length of the leg, which will be shortened? Okay, so this is the region that you are going to see for the posterior dislocation. And for the anterior, same fabir. Here it is fabir. So this is flexion at hip, abduction at thigh region, okay, and external rotation. And how about the length? The length will be increased. It is going to be lengthened. Next, we will be discussing about the hematology drugs, guys. Important some of the drugs. First, most commonly, you have all know that iron, right? So iron is given for the patients those who are suffering from the iron deficiency anemia, because it is going to increase the hemoglobin, right? It will replace the hemoglobin by increasing its synthesis, right? And side effects, when it is comes to the side effects, it can cause the toxicity. Where it can cause the toxicity. To decrease this iron toxicity, what is the antidote that we are going to give for this patient? Deferoxamine. Okay, deferoxamine is given for the deterrent agent that will be given for the iron patient. But when there is a iron increase, the sometimes black color stools is seen, but it is considered to be the just a common side effect only. Next, other drugs like folic acid, vitamin B12 for the different types of the megaloblastic anemia we are going to give, and also neural tube defects that we are also possible. Next, those who are suffering from the CKD, they are decreased erythropoietin, right? So for this patient, we can give the darbepoetin, or we can also give the erythropoietin stimulant. Okay, this is the artificial type of the erythropoietin stimulant, but this is associated with the side effect. It can cause the hypertension. CKD patient already is hypertension, it can also cause the hypertension. Okay, next, those who are suffering from the sickle cell anemia, what happens, we can give that the sickling defect we have to decrease, means we can give the hydroxyurea, the drug can be given for this patient. Next, coming to the antiplatelets, so aspirin. So we all know that and aspirin can work as a anti-uricemic and also hyperuricemic, anti-inflammatory and antiplatelet. So what is the mechanism behind the antiplatelets? So when the patient we are going to give, it is going to cause the decreased COX 1A inhibition, right? It will decrease the COX. So further what it will do, it is going to decrease the whatever the process of the platelet formation, which will be decreased. So that's how it is going to act as a aspirin, but it can cause the ulcer disease. First side effect. Next, another one, we have the clopidogrel. Okay, this clopidogrel, what is the mechanism of the clopidogrel? It will decrease the ADP receptor inhibition. Okay, it will inhibit the ADP receptor. These both are going to act as a platelet antiplatelet drugs. Okay, next, we also have the monoclonal antibody, for example abiximab. So this is going to act on the 2B and 3A blockage. Okay, these are also going to act on this particular things. Next, coming to the anticoagulants, so we have the heparin. Okay, so and also warfarin. So before we see these differences, we will see the last some of the other drugs I want you guys to know. So 10A inhibitor. Okay, 10A inhibitor, this drug is low molecular weight heparin, or also known as a enoxaparin. Okay, enoxaparin. So here you can see 10A within the name of it drug. Okay, next, other agents of the anticoagulants are 2A inhibitor, 2A inhibitor, that is dabigatran, and 10A inhibitors, others such as 10A inhibitors. These are the double agents. For all these drugs are ends with the axaban. Okay, axaban, 10A ban. So rivaroxaban, apixaban, that is going to be seen. Next, we also have the thrombolytics, right? Thrombolytics, in that the best drug that will be used nowadays is the LT-place. Okay, LT-place or the tenecteplase. These are the drugs. And antifibrinolytics like tranexamic acid. These drugs can be also used, but they are some of the drugs which will be acting as a stimulating factors. For example, filgrastim. So this filgrastim drug is going to increase the granulocyte stimulating factor. Okay, it is going to increase the granulocyte stimulating factor, which will further increase the neutrophils in the patient for the progression. Okay, that is the one drug that you have to remember. Next, we will see the difference between the heparin and warfarin. Okay, so first, what is the heparin, guys? Usually this is the indirect anticoagulant, same as the warfarin, but heparin is only seen in the form of the IV. How we are going to use subcutaneous or the IV, and warfarin can be given the oral also. Okay, but how it is going to act as a anticoagulant? It will activate the antithrombin 3. It will activate the antithrombin 3. And in the warfarin, it is going to stop the vitamin K. Vitamin K inhibition will be seen in this patient. So further, the vitamin K is going to act on the clotlet factor of the 2, and also so it is going to act on the 2, 7, 9 and 10. So these are going to be vitamin K important factors, right? So what happens? The bleeding manifestations will be, the coagulation manifestation will be decreased in this patient, right? But which of the following can be very severe conditions? So for the patients of the heparin, what we have to do for this patient, we have to monitor the APTT. Okay, to see is there any coagulation, bleeding is associated with this one. And for this patient, we have to monitor the PTINR. Okay, PTINR should be manifested. Next, heparin or the warfarin both will be associated with the severe kind of the bleeding, and both will be teratogen. Okay, both can be teratogen. Okay, but if what can be used, it is somewhat safe comparing to the warfarin. So warfarin is completely, patient is going to have the teratogenicity is seen in the embryonic period. Next, what is the antidote? So antidote for this, the heparin is the protamine sulfate, and here antidote is the vitamin K. Stop the drugs and give this particular antidotes. Okay, these are the some of the examples for the hematology drugs. Next, coming to the radio sensitive and the radio resistant table. So here in this guys, first cycle phase. So the G1 is considered to be the most resistant cell, is the platelet, is the complete resistant cell to the radiation, nervous tissue and vagina organ. Coming to the sensitivity, G2 is the most sensitive, lymphocyte, bone marrow and the gonads are the radio sensitive particular organs. Next, coming to the radioisotopes. Technetium 99 HIDA scan used for the acute cholecystitis, biliary leak and also biliary stenosis. Next, technetium 99 percutinate, it is used for the thyroid patient, thyroid, salivary glands and Meckel's diverticulum. Next, DMSA scan is used for the kidney. Okay, this is for the kidney function. Next, DTPA is used for the GFR. DMSA, anatomy of the kidney. DTPA is for the GFR. Technetium 99 Sesta scan is for the parathyroid. This is the one of the PYT asked, and MIBG scan is for the pheochromocytoma. Thallium for the myocardial perfusion and MDP scan is for the bone. Gallium is for the lymphocytes, panda scan like for example sarcoidosis also we can see. Next, this 18 FDG, this is the glucose type of PET scan we are going to use for the PET scan and also cancer staging. Next, half-lives. Technetium 99 is always going to be the 6 hours. Here you can see technetium 99 6 hours, technetium 99 6 hours. Next, 18 FDG 110 to 120 minutes. Okay, HIDA scan is 6 hours, gallium is 78 hours, and highest is the iodine. Highest is the iodine, which will be 8 days. Okay, next, coming to the competitive inhibition, non-competitive inhibition. So competitive, non-competitive inhibition, you have to understand the major difference between these conditions are the how the drugs are going to be formed. Okay, so the non-competitive inhibition, the Vmax is going to be decreased in this, and what is going to increase indirectly? If the Vmax is decreased, it is going to increase the, so the non-competitive Vmax is decreased, but Km value is unchanged. Remember, the Km value is going to be unchanged. Okay, so this the non-competitive is going to act like it is going to bind on the different site. Okay, so the binding of site is going to be different. Okay, so the Vmax will be decreased in this patient. Km is unchanged. Okay, next examples for this one is the heavy metals like OP poisoning patients and also cyanide. Okay, OP poisoning and the cyanide. And non-competitive inhibition, when they are on the line, it is no competition between them, so they both cannot meet in the same line. Okay, both are in the different direction. Next, coming to the competitive inhibition, we will see. So competitive inhibition, this is going to resemble same. So the resemble same to same substrate binding is going to be resemble same. Okay, and both are going to act on the same place. So that's why the Km value will be increased and Vmax is going to unchanged. Vmax is going to unchanged in this patient. When they are competition, the both are going to meet at same point in the graph. That is how you can remember the graph. Example, statins. Examples are statins and ethanol poisoning, right? Ethanol or the methanol poisoning. Next, uncompetitive inhibition. Here the Km value is decreased and also Vmax value is decreased. Okay, this is how you have to remember the competitive versus the non-competitive inhibition. All right, next moving on to the pharmacology, guys. In the pharmacology, Hypertension therapy. We have the different types of the hypertension. First, primary hypertension, secondary hypertension, resistant hypertension, and also which of the following will be like urgency and also emergency. These conditions will be also seen in this condition. First, we will see the hypertension urgency. So what is the drug of the choice for this patient? First, hypertension urgency is more than 180 by 110 mmHg of the BP is seen, and no organ damage. So no organ damage will be seen in this patient. So for this patient, the drug of the choice for this is the oral clonidine should be given. Okay, oral clonidine drug is given. Next, hypertension emergency. So hypertension emergency. So this is seen in most likely those who are same with the 180 by 110 mm Hg, but this patient will be having the organ involvement. Okay, so like creatinine is raised, patient is having the stroke paralysis. These kind of particular symptoms will be seen in this patient. For this patient, the drug of the choice for this patient will be the commonly in the hypertension emergency, we are going to use the labetalol. Okay, labetalol is given for these patients. Okay, that is the first thing. But this is labetalol is given in the pregnancy and outpatient department in the emergency examination. But according to the exam, you better choose the nicardipine. Okay, nicardipine should be chosen for the option for the hypertension emergency. Next, what the first line therapy for the patients those who are suffering from the hypertension in the first stage. Okay, for this patient, ACE inhibitors like enalapril, resinopril, or the herb drugs like losartan, telmisartan should be given for this patient. Okay, next, those who are suffering from the CKD, diabetes mellitus, or the hypertension patient, COMAPS. So for this patient, ACE inhibitors are the herbs should be given for this patient. Next, those who are suffering from the resistant hypertension. What is meant by the resistant hypertension, guys? At least I added the two dual drugs. Okay, two dual drugs is added, and in these two dual drugs, one among that is the diuretics, but still it is not controlling. For this patient, the drug of the choice is the spironolactone. Spironolactone should be given for this patient. And another associated condition for the patient, pheochromocytoma. For the patient, pheochromocytoma. For this patient, we are going to give the phenoxybenazine. Phenoxybenazimine can be given for this patient. Okay, those who are suffering from the osteoporosis, for this patient, thiazides is given. Those who are suffering the benign prostatic hyperplasia, prazosin. For those who are suffering from the Raynaud's phenomena, calcium channel blockers is given for this patient. Okay, and those who are suffering from the migraine and patients who are with the anxiety like psychiatric conditions, for this patient beta blockers is given because it is going to decrease the heart rate and also prophylaxis for the migraine. Okay, this is how we are going to follow the hypertension therapy. Next, coming to the Burns classification. In the Burns classification, we are going to use this 9 rule. Okay, rule of 9 we are going to follow. So what is this rule of 9 will tell, guys? Basically, the rule of 9 which will be working on the patients when they are presented with the Burns, adults we are going to follow. Okay, next, along with that, same as the children also, same formula which will be applied for this patient also. Okay, what is the parts that has been given? The front and back 18%, whole head will be 18%, arms 9%, and both the down arms will be 14% for this patient. Okay, next, coming to the adults, head is 9%, front 18, back 18, both arms each 9 and 18% is given. So the anal region 1% is given. So total 100% of the classification is given for the patients of the Burns. Okay, this is how we are going to calculate for the patients for the fluid resuscitation. Okay, and what is the formula that is commonly used for this patient, guys? Parkland formula. So whenever we see these patients with the Burns, you have to follow the Parkland's formula. What is the Parkland's formula? Nowadays we are going to use the Parkland formula with the 4 ml. Okay, 4 ml total per 4 ml per kg into total body surface area involved for the Burns. That is how we are going to calculate. Okay, this is for the all the patients those who are suffering from the not only from this condition like Burns, in the babies, and also the scald buns also we are going to use this one only. This is known as a Parkland formula. A Parkland formula. How we are going to give? First, it is divided into the 24 hours. First half of the fluid is given for the 8 hours, and second half of the fluid is given for the 16 hours. Okay, this is how we are going to give. Basically, in the burns patient, what happens? There is a decreased airway. So what you have to do? Better go for the patient's oxygen therapy, and also if they are severe, then we have to go for the patients with the ventilation also given for this patient. Okay, next, the zones of the burns also completely diagnosed well. And coming to the degrees of the burn, how we are going to diagnose this degree of the burn? So this is the first degree of the burns. First degree burns is going to involve only the epidermis. Okay, if it is involved, it is going to involve the epidermis region. Okay, next, second degree burns. So second degree burns is divided into the two types, guys. Okay, second degree is divided into the two types. One is the superficial and other one is the deep. Okay, so the first superficial is going to involve epidermis plus papillary dermis. Only half of the dermis that is involved. Okay, but in the deep, both epidermis and the dermis is involved in this patient. This is the second degree. Next, third degree, and we can also add fourth degree burns. So fourth degree burns, subcutaneous tissue is involved, and if muscle is involved here, this is considered as a fourth degree burns. Okay, this is considered as a fourth type of the degree burns. Okay, always remember, always sulfur dioxide, that ointment is given, and immediately fluid resuscitation is started for this patient. Regardless, the fluid resuscitation is only going to save this patients. Next, cause of death. If it is an immediate cause of death, if it is an immediate cause of death, most commonly due to whatever the burns, that is caused the asphyxia. If it is early death, like 1 to 2 3 days, then this is due to shock. Okay, hypovolemia, fluid loss is common. Next, late, more than 3 days, this is due to sepsis. Okay, sepsis patient. And sepsis, the most common cause organism is the pseudomonas. Pseudomonas is the most common. Okay, this is the overview of the burns. Next, moving on to the abdominal trauma. Whenever you see abdominal trauma, you have to see whether it is a blunt trauma or the penetrating trauma. Okay, this is how we are going to distinguish between how to treat this patient. Okay, first, if you are seeing here in the pictures, here you can see this is the blunt trauma, and the second pic, that is the patient is suffering from the penetrating trauma. So whenever you see this condition, first has to be done fast. Okay, so fast or the e-fast should be done. So if the e-fast is positive, then look after for the patient stable vitals. If the patient is stable, then better go for the CECT, because this is the investigation of the choice. But if the patient is unstable, if the patient is unstable, then you have to go for the patient fast only. Again, fast should be done, and in that fast, if you see any abnormality, then go for the laparotomy. Okay, laparotomy should be done for this patient. This is how we are going to proceed for the patients of the blunt abdominal trauma. Next, penetrating abdominal trauma. It is divided into the two types. One is superficial. One is the superficial penetrating trauma. So for this patient, locally you can explore, and whatever that came out now, you have to put that manual replacement, and then close the suture. Okay, and next proceed for the CECT. 2 is to see if there is any further damage. But if it is going to involve the peritoneum, then we have to proceed for the laparotomy. And never insert this in the ER. Okay, there is a high risk in the bleeding risk, so you have to always proceed for the patient with the OT only. Okay, next, this is known as a seat belt injury. Okay, seat belt injury, here classically you can see this is the seat belt injury. So seat belt injury is commonly seen in the patients, those who are having the road traffic accident or the car accident, right? So in this patient, what is the common features that you are going to see? How can you identify this patients with a seat belt injury? Okay, first, seat belt injury can most commonly injure us to the mesentery. It can injury to the mesentery, and it can also cause the chance fracture. It can cause the chance fracture. What is the chance fracture? It is seen in the spinal vertebrae will be causing the chance fracture, and mesentery is the one which will be going to involved, right? This is how we have to understand. Blunt fracture, if it is a blunt fracture, the most common organ will be liver. If it is a penetrating, if it is a penetrating, then the most common type is the spleen, which will be causing. Okay, this is how you have to understand about the abdominal trauma. Next, moving on to the ulcerations, types of ulcers. Here you can see the sloping edge seen in the healing ulcers, and punched out seen in the syphilis, and undermined edges like this, undermined edges seen in the tuberculosis, rolled edges seen in the basal cell carcinoma, everted edges seen in the squamous cell carcinoma. Okay, these are the types of the ulcers that you are going to see. Next, coming to the different types. So this is known as a venous ulcer. This is known as a arterial ulcer. And here, this is the neuropathic, and this is the pressure sore. This is the pressure sore. So how can we see how what are the locations, ulcer locations and characteristics? So the venous ulcers will be looks like flat. Okay, so there will be exudate. So there will be exudate which will be presented, and granulation is also seen. Okay, that is considered to be as a venous ulcer. Next, coming to the arterial, mostly you are going to see the punched out lesion. Okay, and irregular shape will be seen, and presence of the necrosis that is seen in the arterial ulcer. Next, coming to the neuropathic is deep ulcer, and also there will be cavity formation. Okay, cavity formation is also seen. Pressure ulcers is more deep, is going to be more deep, and ulcerations are seen. Okay, surrounding tissue ulcerations will be seen. Okay, and this is how we are going to treat this. We are going to understand what is the difference between these types of ulcers. If we see the conditions that are associated, varicose veins. Okay, varicose veins, we see in the seat classification. Okay, and also pregnancy patient will be also associated with this condition. Obesity, those who are suffering from the deep vein thrombosis, and other conditions like diabetes mellitus, pressure and hypertension, smoking, these patients will be associated with the arterial. Next, neuropathic, diabetes mellitus, trauma, and here pressure ulcers, mostly old age people, those who are immobile. Okay, lack of ambulation will be associated with it. Next, moving on to the rabies condition. So in the rabies condition, first you have to take note about the what is the classification, WHO criteria, and then how we are going to treat this patient. Okay, that is the first thing that you have to understand for the rabies. Okay, let's see. First, the patient, those who are suffering from the rabies, is characterized into the three kinds of the exposure. So the class 1, class 2, and class 3. So patient with the class 1, no exposure at all. Okay, they doesn't have the exposure, just they touch or feed the animals with their hands. Okay, so for this patient, no treatment is needed. No treatment unless or until if there is a wound, you can just clean up and antiseptic should be applied. That's it. Next, the patients with the class 2, they already exposure that will be seen due to nibbling of the intact skin is intact here. Okay, for this patient we can give the anti-rabies vaccine should be given for this patient. Okay, next, those who are have the severe exposure, that means the skin or the mucosa that has been contact with the saliva, blood, or patient is bleeding, all these patient we are going to give the ARV, along with that rabies immunoglobulin should be given for this patient. Okay, next, the classification of the exposure. Post exposure prophylaxis. post-exposure prophylaxis is given in the two types. One is the Thai regimen and other one is the SN regimen. So the letters itself you have to remember. Four letters for the Thai regimen. So it is given on the third day, the first 0 day, third day, seventh day, and 28th day. And SN five letters 0, 3, 7, 14, 28. Okay, next pre-exposure before. For example, those who are in the forest officers, for them pre-exposure is given. So for the pre-exposure, we are going to give in the three doses. 1, 2, 3 letters pre-exposure 0, 7, 21 or 28 they can go. Okay, next re-exposure. If the patient is had this condition more than 3 months, more than 3 years ago, then we can give. How many doses? 0 and 3 doses should be given for this patient. Okay, this is how we are going to follow the prophylaxis for the rabies. So rabies is going to have the negri bodies. Okay, negri bodies you are going to see. And where the post-mortem finding you are going to see from the hippocampus. From the hippocampus, you are going to see this one. Negri bodies are the inclusion bodies that you are going to see. Next, moving on to the tetanus. Tetanus can be very detrimental. Here you can see this position. The spastic paralysis will be seen in the tetanus patient. So that's why we have to understand how we are going to proceed. So there are four categories for the tetanus. Okay, there are total four categories for this patient. Patient A, he is immunized to the tetany. He is immunized to the tetany, but the history is less than 5 years. And another patient also immunized, but his history is 5 to 10 years. Okay, and this patient is immunized, but his history is more than 10 years. And here unknown history. Immunization history will be unknown history for this patient. So for this patient, if they had the injury, let's say this is the clean wound and this is the contaminated wound. Contaminated wound. So what we are going to proceed with this means, if they are immunized less than 5 years, okay, just wound care is applied. No need to go for the TT injection. Okay, wound care is given because TT injection can be work for the up to 10 years. So just wound care is enough. So 5 to 10 years means the patient wound care is given. Along with that, TT one dose can be given. Same as here, wound care plus TT one dose is given for this patient. Next, more than 10 years, wound care plus TT that is given, and here wound care plus TT plus human immunoglobulin is given. Okay. Next, unknown history, then wound care along with the TT and also human immunoglobulin plus this patient complete the course of the TT injection. Complete course should be given. So here also wound care plus TT plus human immunoglobulin and complete course. Complete course is given for this patient. Next, moving on to the CNS course. First, Glasgow Coma Scale. So in the Glasgow Coma Scale, eye opening is given as a 4 points. Okay, up to 4 points. 4 is for the normal. 3 is for the eyes open to verbal response, and 2 is for the eyes open to the pain, and 1 is for no pain. Okay, no response at all for the eye. Next, verbal is given as a 5 points. 5 is for the normal patients and 4 is for the confused but able to answer. 3 inappropriate responses. 2 is for the inappropriate sounds or the incomprehensible sounds. 1 is for the verbal response, no verbal response. Next, motor is given as a 6. Okay. So if he obeys to our commands, 6 is given. Purposefully only for the pain, 5. Withdraws from the pain, 4. And abnormal flexion, decorticate posture, that is 3. And decerebrate or the extension, that is 2. And no motor at large, 1. Okay. So GCS score is total comprises of the 15. If it is less than 8, the condition is severe. Even in the patients of the dead patient, the score will be 3 only. Okay, that you have to remember. Next, moving on to the ABCD score. A for age more than 60 years, 1 point, and B for blood pressure more than 140 and 90, 1 point, and C for clinical features such as speech impairment, 1 point, unilateral weakness, 2 points. Duration, D for 10 to 59 minutes, within less than 1 hour, 1 point, more than 1 hour, 2 points. Another D for the diabetes for the 1. So this is going to decide for the patient, those who are suffering from the stroke. Next, another one, B fast. B for balance is lost, E for eye abnormality, F for face paralysis, and A for arms paralysis, S for the speech impairment, T for time, immediately call the ambulance. Again, that is also for the patients, those who have the stroke. Next, CHAD scoring. This is for the risk factor for the stroke. Okay, cerebrovascular accident we are going to check. C for congestive heart failure, H for hypertension, age 75. If they are more than 75, we are going to give the 2 points. D for diabetes mellitus, S2 previous history of the stroke, transient ischemic attack, and the thromboembolism. Again, 2 points is given for this patient. Vascular disease, 1 point. Age less than 65 to 74, 1 point. Sex, if she is a female, 1 point is given. So this is for the another criteria that we are going to follow for the stroke patients. Next, we are moving on to the healthcare infrastructure in India. This is the logo for the National Health Mission, guys. And next, moving on to the mostly what is the population and how they are subdivided. Okay, so here you can see this is the subcenter. This is the subcenter. This is the PHC, primary health center. This is the community health center and district hospital. After that, medical colleges and super specialty hospitals. So for the sub-centers, hilly areas, usually for the 3000 population. Okay, and for the plain areas, it is for the 5000 population. For the PHCs, hilly areas, 20,000. For the plain areas, it is 30,000. Okay, next CHCs, hilly areas 80,000, and for the plain areas 1,20,000. For the district hospitals, plain areas only we are going to have the district hospital more than 1,50,000 to approximately even 2 lakhs also. That is C. Okay, next in the patients in the center, sub-center, there will be only multi-purpose worker male and multi-purpose worker female will be presented. In the PHCs, you are going to see the medical officer and also MPWs and nursing staff, pharmacy staff will be seen. Okay, so approximately 10 to 15 staff will be present. Here 2 to 5 staff will be presented. Next, the patients, as for example, CHC. In the CHC, you are going to have the specialist also. Physician will be seen. Surgery, if the surgery is seen, anesthesia will be also seen. Okay, obstetrics, gynecologist. If the obstetric gynecologist, obviously pediatrician will be presented, and ophthalmology will also be seen. Along with them, pharmacy and lab technicians and also nursing. Okay, around 40 staff will be seen here. Next, district hospital, mostly all super specialization also. Super specialization will see and a specialist will also present. And district hospital differences, here blood bank is also present. Okay, blood bank, labs, staff nurse, nursing staff, okay, full established nursing staff, and administration is also seen. So more than 55 plus staff people will be seen. And here you can see these are ASHA workers and these are Anganwadi workers. Okay, Anganwadi workers, this is comes under the ICDS center, right? ICDS centers, Anganwadi workers will be seen. ASHA workers, what is the minimum criteria for the ASHA workers? For urban, 1 out of 2500 population, ASHA should be present. For the rural region, 1 out of 1000 population, ASHA should be presented. Okay, she should be female and at least more than 40 years or less than, not less than less, at least 20 to 40 years minimum age and 10th class pass and more than 1 to 2 children should be presented so that she can understand that empathy, everything that towards the children, towards the patients. And also she should be belong to that permanent resident. She should be belong to that permanent resident of the village she assigned. And what is the purposes she will do? Home visit. Okay, home visit and delivery. She cannot get do the delivery, but she can assist or else she can facilitate. In the good words, she can facilitate to district hospital or the community health centers. She has to facilitate the patients towards the delivery. Okay, next, mother and child health care, like she can give the iron folic acid or also immunizations as needed, antenatal visits, immunizations, antenatal visits. She can also go for that. Next, documentation. For example, birth rate, death rate, and what are the epidemics like polio, or if she had seen the cholera, this can be also seen. Next, sanitation campaign. She can also do the sanitation campaign. Okay, what are the drugs she can give? TB drugs, iron folic acid, antibiotics, and the ORS. And she will be educating. Okay, educating about the health management at the PHC centers. Okay, that is the one thing also she can do. Next, in the urban population also, you have to take note of some of the important points. In the urban National Urban Health Mission. In the National Urban Health Mission, urban PHC, urban no subcenters, urban PHC around 10,000 population. Okay, urban CHC 2,50,000. Urban district hospital 6 lakhs. Okay, that will be presented. Next, MPW male, MPW female, multi-purpose workers female, multi-purpose worker male. What they are going to do? So multi-purpose worker female, she can conduct the normal delivery. She can conduct the normal delivery, antenatal visits she can do, and also she can give the immunizations. Immunizations should be done, and also family planning can be also done. Here, family planning, okay, malaria test and also sputum test that can be done. Okay, malaria means you can consider the other vector borne diseases also. Chlorination, okay, maintaining of the register, cold chain, maintaining the cold chain of the vaccination, and OPD survey, OPD and survey. This is done by the multipurpose worker and the multipurpose worker female. So, okay, Anganwadi worker, basically at the Anganwadi, you are going to see mostly more than 400 to 800 population, one Anganwadi worker. Okay, this is how we are going to see them. And what are their role? Anganwadi workers, especially they are going to see after the children 0 to 6 years, they are going to see. Okay, 0 to 6 years. And also pregnancy care in the sense of diet and the immunization, and also lactation. Okay, lactation, women and child welfare, such as those who are from the 14 to 15 to 49 years, and also adolescents girls 10 to 19 years. They are going to help them. Okay, this is the Anganwadi workers. Next, moving on to the CSF analysis. In the CSF analysis, here you can see normal, there will be no WBC count, no protein, no glucose. Okay, everything will be in the normal. What is the protein value? 20 to 45. Glucose is 50 to 75%. Clear, and there will be no pressure also, less than 28 centimeters. For the bacterial, there will be severe neutrophils. You are going to see the severe neutrophils, along with that increased pressure, increased protein, and decreased glucose. Coming to the tuberculosis, it will be mostly covered by the lymphocytes, and in the bacterial neutrophils, and high protein is seen in the tuberculosis, and decreased glucose is common, and cobweb formation will be seen. So there is a cobweb formation is seen inside the tube. Viral is going to mimic as a normal only. So normal pressure, only lymphocytes, and the elevation of the protein is also just a small 50 to 150, and normal glucose. So sometimes viral is going to mimic the this condition. Okay, this is the CSF analysis. Next, moving on to the myasthenia gravis. So in the myasthenia gravis, we have here two conditions. Already I explained in the medicine class. So what is this condition, guys? Lambert-Eaton syndrome. This is the Lambert-Eaton syndrome. What is the Lambert-Eaton syndrome? Mostly this is affected in the presynaptic. This is affected in the presynaptic. This is affected in the postsynaptic. Okay, here voltage gated calcium channels, here acetylcholine receptors that is defected. Okay, so the patients by the day they are very inactive. This patient will be very inactive. By the time of the night, there will be active. Okay, that is why. So when you see the lamp in the night, they will be active, but myasthenia patients are very dull. Next, here acetylcholine receptors, right? So in the day they will be active. So by the day completes, in the night these patients will be inactive. This is the major differences. Okay, and they are associated with the small cell lung carcinoma. Small cell lung carcinoma. Here it is associated with the thymoma. What are the drug of the choices for the treatment? Here 3,4-diamino, 3,4-diamino pyridine, and here the drug of the choice is the pyridostigmine. Pyridostigmine. Next, overview of the myasthenia gravis. Most specific test. The most specific test is antibodies. In that, most common is the acetylcholine receptors is positive. After that, musk receptors, and other than that, you are also going to see the lipoprotein. Lipoprotein receptors will be also positive. This is the most specific. When it is comes to the most sensitive, it is nerve fiber test. Nerve fiber test is the most sensitive. Most common test that we are going to do, the most common test that we are going to do is also nerve fiber test only. Okay, nerve fiber test that we are going to perform in this patient. Next, hydrophonium test. In the hydrophonium test, what is the drug that we are going to, sorry, hydrophonium is the drug that we are going to use, and the test name is tensilon test. Test name is the tensilon test. What is the first symptom that you are going to see? Ptosis. Okay, over then that proximal muscles, and then distal muscles also involved, and over the time, if it is a severe condition, it is going to involve the facial muscles. Okay, facial muscles also involves, and then internal muscles, and it can cause the cause of death. Example, diaphragm. If the diaphragm will involve, it can cause the paralysis. Okay, these are the overview of the myasthenia gravis. Next, moving on to the retinal detachment. There are three types of the retinal detachments, right? One of the common one, most common is the regmatogenous type of the retinal detachment, and other type is the tractional and the exudative. So among these, the most common is the regmatogenous, guys. Okay, so in the regmatogenous, what could be the symptoms that you are going to see in this patient when they are suffered from this condition? Okay, that is the differences that you have to take note from the regmatogenous and tractional and also exudative type. Okay, we will discuss now what is the differences that you have to find in these types. First, regmatogenous, the most common type is the myopia. So when there is an increased myopia, it can cause the regmatogenous type of the retinal detachment. Okay, and the patient symptoms will be like curtain falling. The patient will be telling that curtain falling like symptom that has been seen. And next, also you are going to see the floaters. Floaters will be seen. Photopsia. Photopsia is also seen in this patient. Next, on the test, like when you see this patient, you are going to do the scanning. Under the scanning, you are going to see tobacco smoke, tobacco smoke appearance. Tobacco smoke appearances will be seen in this patient. Okay, that is one. Next, another feature, Marcus gun pupils. Marcus gun pupils. So these Marcus gun pupils are seen in the myopia also. Okay, next, coming to the tractional. Tractional is most commonly due to diabetes mellitus, and same findings the patient will be having the curtain falling, curtain fallen symptoms. But on the test, you are going to see the demarcation lines. There will be demarcation lines in the retina. Okay, and coming to the exudative. Coming to the exudative, this is most common with the melanoma or choroid, whichever involving with the tumor. Okay, but positively on the test, you are going to see the fluid accumulation. Fluid accumulation is seen in this patient. Same symptom, curtain falling will be seen. Okay, Marcus gun pupil is seen here also. Marcus gun people is seen here also. Only the test differentiation will be telling us what is that type. Okay, next moving on to the MTP. So MTP is the common or most important part I can say in the examination of our FMG. Sorry guys. We are going to follow the new amendment that is released by the state from our central government 2022 amendment. So the 2022 amendment is telling that up to 24 weeks we can do the abortion. Okay, medical abortion can be done for this patient. But what is the procedure behind this? If it is a 20 weeks, okay, one doctor opinion is fine. And if it is more than 20 weeks, then we need that two doctors. If it is more than 24 weeks, beyond that, we need the board. Okay, that board meeting will be consisting of the radiologist and also obstetrics gynecologist and pediatrician. Unless or until if it is a severe condition like rape cases or patient is at the threat, maternal is at the death, but if it is a baby is going to die, then only we are going to move for the board. Next, contraception. If it is a contraceptive failure, then only less than 20 weeks are allowed. Only less than 20 weeks are allowed. And who can perform? Registered medical practitioner who has done more than 25 assistant, 25 as an assistant and more than or equal to 5 by him or herself, they can only perform. Okay, that's how. Next, consent. Coming to the consent, only female is enough. And if the female is less than 18 years and if she is mentally retarded, then only we are going to proceed for the guardian. But male is not needed. Okay. And you have to maintain the records. 5 years record should be maintained. And within the 72 hours, you have to produce if ever they have asked. And no need of the information about the personal details. Also, that is also not needed for this patient. Next, medical abortion. This is done less than 9 weeks only. So, medical abortion, you are going to give the drugs on the day 1, mifepristone, almost 200 mg orally, one dose is enough. Next, after 1 day gap on the day 3, misoprostol is given. This is given 800 micrograms. It can be given vaginally or it can be given as a orally. Okay. Next, after that, surgical more than 9 weeks, we are going to use the suction and evacuation. Suction and evacuation is used for this people. Next, here the picture of the types of abortions. What is the most common cause for the types of abortion, guys? Aneuploidy is the most common cause. Okay, other than that, trisomy. Other than that, monosomy. Okay, this is how you have to identify what is the most common cause. Next, threatened abortion, cervical os is in the in the threatened abortion, the cervical os is closed. Heart rate is present. So, what you are going to treat? Conservative. Next, inevitable. This is going to be irreversible because cervical os is open. Cardiac heart rate is not present. Okay, cardiac heart rate is not present. So, for this patient, dilatation and curettage should be done. Evacuate as soon as possible. Next, another type here you can see. This is the incomplete type. So, in the incomplete type, the cervical os is open. Some of the products is still present. So, cardiac rate is also not present. So, for this patient also, dilatation and curettage is the treatment. Next, here cervical os is closed. Heart rate is not present because completely evacuated. Nothing is present. So, for this patient, just observation. Okay. And missed abortion, the products is still inside only. Cardiac output is not there and also patient's os is closed. So, for this patient also, we are going to do the suction and evacuation. Okay, this is the abortions types and what is the treatment that we are going to follow for them. Next, moving on to the ASA grading. Okay, in the ASA grading, you have to important what is the grading that we are going to give for this patient. Basically, the ASA grading is given like a 6 points. Each patient is given as a 1, 1, 2, 3, 4, 5, 6 based on their particular disorders, whatever their associated condition that we are going to follow. Okay, first, this patient is healthy, okay, normal, no comorbs. Okay, next, grade 2, only comorbids present such as diabetes mellitus, hypertension, asthma, plus they are on the medications, controlled medication that the patient is taking. Grade 3, the patient is hypertension. Okay, this is severity. So there is a risk for myocardial infarction or the cerebrovascular accident. Okay, next, fourth class, this patient is threat to life. Okay, fourth patient is threat to life. For example, previous history, already the patient is having the history of MI, cerebrovascular accident, or some other thrombosis condition. This is the constant threat to the life. Fifth grade. So fifth grade. Sorry guys. Fifth grade, this patient is surgery is the only choice. Surgery is the only choice to let them leave. Sixth patient, sixth grade, the patient is coma or brain dead. Coma and brain dead. This is the following that we are going to follow. Next, here I want to also guys to understand about the Mallampati score. So what is the Mallampati score is used especially for the intubation, right? Intubation purposes, airway we are going to use. For the class 1, this patient will be visualization will be normal. Okay, visualization will be normal. So you are going to see the soft palate, hard palate, and also uvula, tonsillar pillars, all will be seen in this the class 1. Next, class 2. In the class 2 patients, what happens? There will be visualization only to the uvula. Uvula is seen, soft and also hard palate is seen. Tonsillar pillars are not seen. Next, class 3. Here only the base of uvula is seen. Base of the uvula is seen. Next, class 4. Okay, not even uvula. Okay, not even uvula or the soft palate is seen. So, in the intubation, for the patients, those who are intubating, for the intubation, class 3 and 4 is difficult to proceed. Class 1 and 2 is normal to proceed. Okay, this is the Mallampati scoring. Next, moving on to the adrenal disorders. Okay, moving on to the adrenal disorders, we are going to discuss. Here you can see these are the different types of the adrenal glands that is present. In this adrenal glands, we are going to see the different hormones, right? From the cortex, outer layers, zona glomerulosa, zona fasciculata, zona reticularis. Glomerulosa is going to produce the mineralocorticoids like aldosterone, and zona fasciculata is going to produce the glucocorticoids like cortisol and the cortisone. Next, for the androgens, dihydrotestosterone and other androgens will be produced here. Next, coming to the stress hormone, this is present in the medulla. Sympathetic activity like catecholamines, epinephrine and the norepinephrine will be seen. Next, we will see the diseases, guys. What are the diseases that will be associated with this condition? First, we will see the medulla. With the medulla, you are going to have the condition that is known as a pheochromocytoma. So these patient, those who are suffering from the pheochromocytoma, they are going to have the increased epinephrine and increased norepinephrine. So further it will increase the sympathetic activity. Sympathetic activity will be seen. This is the most common benign tumor in the suprarenal gland. Okay, and it follows the rule of 10. 10% will be bilateral, 10% will be malignant, 10% will be malignant. Only 10% of the people will show the symptoms. All over that, 10% is the extra-adrenal. It can also involve the extra-adrenal sites. So, what is the patient symptoms will be? You are going to see the classical triad. The patient will be having the headache and resistant hypertension will be seen. Along with that, there will be palpitations. Okay, palpitation will be also seen in this patient. Okay, and for this, we are going to start this patient on the phenoxybenazine. That drug can be started for this patient. Treatment for the hypertension. Okay, recurrent attacks will be seen. And when you want to cure this patient, the investigation of the choice is the metanephrine levels. Okay, metanephrine levels should be tested. And treatment is surgery, excision. But during the surgery, you have to first start on the alpha drugs, then move for the beta blockers, and then cure. How cure? Excision is the choice, right? A, B, C. Alpha, beta, cure. This is how we are going to proceed. Next, moving on to the cortex. In the cortex, commonly we see the Cons syndrome. So Cons syndrome, this is due to increased aldosterone. Increased aldosterone, basically due to adenoma. Okay, adrenal adenoma is the cause for the Cons syndrome. So this patient, when the aldosterone is increased, it will increase the sodium along with the water. It will decrease the potassium and also H plus ions. So the symptoms basically coming from the aldosterone action, the patient will be having the hypertension, increased hypernatremia, hypernatremia will be seen, and also hypokalemia, which will be causing the arrhythmias in the patient, and H plus ions also decrease, which will cause the metabolic alkalosis. Okay, metabolic alkalosis. Investigation of the choice is the saline infusion test. Saline infusion test should be done, and treatment is spironolactone. Spironolactone is given for this patient. Okay, this is the Cons syndrome overview. Next, Addison's disease. For the Addison's disease, the most common cause in the India is TB. All over the world is patient is suffering from the HIV. Okay. Next, aldosterone is, see, Addison's disease is opposite. So here, adrenal action is completely down. So opposite to the Cons syndrome, this patient will be suffering from the hypotension, hyperkalemia, and hyponatremia and metabolic acidosis will be seen. Okay, all other drugs is also decreased. So hyperpigmentation will be seen due to the androgens decreation, and the patient will be having the hypoglycemia due to cortisol is not working properly, and also other conditions like hypoglycemia is also seen. Then libido changes will be also seen in this patient. Okay, that is the aldosterone, sorry, Addison's condition. Drug of the choice for this patient is the hydrocortisone. Investigation of the choice is ACTH stimulation test. Okay, next, moving on to the Cushing syndrome. So Cushing syndrome, the most common cause is the iatrogenic cause. The symptoms will be moon phases, CNS irritability, edema, GI distress. Females have the amenorrhea hirsutism and purple bruises, and fat will be deposited in the back and the shoulders. Osteoporosis will be seen. And if it is coming from the pituitary, adenoma, then you call this as a Cushing disease. Cushing disease. And it is also associated with the squamous cell carcinoma of lung. Okay, because of the paraneoplastic syndrome. Investigation of the choice is the dexamethasone. Investigation of the choice is the dexamethasone suppression test. Next, treatment for this patient is the stop the steroids if it is a iatrogenic cause and taper the dosage. You cannot stop immediately. At least a tapering should be done. Next, emergency contraception. So in the emergency contraception, you have the condition, right? So what is this condition, guys? Emergency contraception. Basically, whoever is having this patients, those who are suffering from the emergency contraception, they need if they had the unprotected intercourse, right? Most commonly, we are going to use this one. This is known as a I pill, commonly known, and this I pill, which will be consisting of the levonorgestrel. This is going to consist of the levonorgestrel. And what is the dosage? 1.5 mg. And how long it is going to work? Less than 72 hours it is going to work. Okay, this is the most common method used. And next, we also have the UCP method. Okay, we also have the UCP method. So in this, you are going to take the OCP, and OCP consists of ethinostradiol and the norgosterol. How you are going to take? It is going to take as a 2 tablets. You are going to take the 2 tablets on the day 1, okay, and after that 12 hours after, same day you are going to take, same day day 1, another 2 tablets. So 4 tablets is taken as a UCP method. Okay, next, ulipristol. Ulipristol. This ulipristol is a 30 mg single dose, but it is very best method. So it has a very high sensitivity, and single dose 30 mg is taken. This is also less than 72 hours. Next, another one is the mifepristone. 50 mg single dose, less effective. Next, IUCD, intrauterine device insertion. This is done less than 5 days, and it is also effective. Okay, most effective IUD, best sensitive than the ulipristol. Commonly used is the levonorgestrel. Okay, these are the methods that we are going to follow for the emergency contraception. Okay, next, moving on to the cystic fibrosis. So in the patients, those who are suffering from the cystic fibrosis, we are going to see commonly what is the gene that is involved here, guys. Cystic fibrosis patient, this is the autosomal recessive condition, right? It is an autosomal recessive condition. And what is the chromosome that is involved in this patient? The chromosome that is involved here is the 7q. 7q chromosome is involved. This 7q chromosome, which will be mutated with the CFTR gene. So this CFTR gene will worsens the condition by decreasing the chloride levels and increasing the sodium absorption. If these both are matched, it is going to form the thick fluids in the body, such as mucus and also enzymes from the pancreas. Okay, enzymes from the pancreas is going to be thick formation will be formed. Okay, CFTR gene. Next, most commonly it is going to affect the lungs. Okay, lungs is the most commonly affected. So recurrent, this patient will be having the recurrent mucus problems, and it can continue to the pneumonia. Pneumonia will be seen, and if the pneumonia is affected, most common one is a staph aureus. Progression can be to the pseudomonas also due to immunosuppression, and along with that, the involvement of the pancreas is also seen. Okay, pancreas also seen, steatorrhea, and also fat soluble ADEK, decreased absorption will be seen. Endocrine, pancreas is involved, then the endocrine damage, diabetes mellitus will be seen in this patient. Reproduction, so in the reproduction factors, there will be infertility. There will be infertility is also seen. So the best test for this patient is the sweat chloride test. Sweat chloride test, on the 2 occasions, it should be more than 60 millimoles per liter. That is has to be positive. Okay, treatment, coming to the treatment is supportive. Supportive treatment, treat the pneumonia or the underlying conditions. Okay, next, the new drugs that has been given is the cafters. Caftor means this is all end with the caftor, such as ivacaftor. These are modulator. Okay, CFTR modulators. CFTR modulator that we are going to see. Okay, this is the cystic fibrosis, right? This is the overview of the cystic fibrosis. Next, we are moving on to the specific drug and the side effects. So first, we are going to discuss about the atropine. Okay, atropine is going to be form the anticholinergic. So it is going to show the anticholinergic effects. What are those anticholinergic effects? It is going to show the dry mouth, okay, and flushing of the skin, hyperthermia, increased temperature will be seen, and mydriasis, okay, dilatation of the pupils will be seen in this patient, and also urinary retention. Urinary retention will be seen. So along with the temperature, it can increase the heart rate also. So which will cause the confusion due to sudden this vascular, whatever the vascular phenomena in the cerebral also will cause the confusion and the delirium. This is commonly seen in the patients of the atropine poisoning. Next drug we are going to see is the digoxin. Okay, digoxin mechanism is, it is going to inhibit the sodium and potassium ATPase. And what are the symptoms? The side effects will be associated here, guys. Diarrhea, okay, and also dysrhythmia, and also the patient will be having the irregular heart rate which will be decreased, and GI upset like nausea and vomiting and yellow vision. Okay, yellow vision will be seen in this patient. Next drug, amiodarone. The next drug is the amiodarone. In the amiodarone, mostly this is an anti-arrhythmic drug. It can cause the pulmonary fibrosis. So in the patient, it can cause the pulmonary fibrosis, and also it is hepatotoxic. It will increase the hepatic levels, can cause the hypothyroidism because of this iode in this one, hypothyroidism, and also photosensitivity. Okay, photosensitivity, corneal deposit. Corneal deposits will also be seen in this patient. Next, yesterday we discussed about the lithium and also the phenytoin. Next, we also have the cyclosporine. Okay, the drug cyclosporine. Cyclosporine can be nephrotoxic. It can be the nephrotoxic, and it can cause the hypertension in the patient. Tremors will be seen. So if it is across the blood-brain barrier, it can also cause the seizures, hyperplasia of the gingivas. Okay, hyperplasia of the gingivas. Next, it can also cause the hirsutism. Hirsutism is also seen in this patient. Okay, these are the some of the side effects seen with the patients of those who are taking the amiodarone. Okay, sorry, cyclosporine. Next, for example, pulmonary fibrosis is present. So these pulmonary fibrosis, which will be caused by the multiple drugs. Okay, so pulmonary fibrosis is commonly associated with the bleomycin. Okay, it can be associated with the bleomycin and methotrexate. It can be associated with the methotrexate and cyclophosphamide. Cyclophosphamide will be seen, and amiodarone, and busulfan nitrofurantine. Okay, nitrofurantine. These are the drugs that will be seen with the pulmonary fibrosis. Next, agranulocytosis. Agranulocytosis. This is seen with the C type of the drugs. Okay, first clozapine, antipsychotic drug, and carbimazole, carbimazole, and carbamazepine drug. It can also see with the colchicine, okay, and chloramphenicol also seen, right? These some of the drugs that will be causing the agranulocytosis. Next, some of the drugs can cause the gynecomastia. Okay, gynecomastia is also seen. Gynecomastia is seen with the spironolactone. It can be due to spironolactone, digoxin, okay, cimetidine, alcohol, chronic alcohol people also associated with this, and ketoconazole. Ketoconazole also seen with this condition. Next, lupus, drug-induced lupus, that is associated with the ship sulfur drugs, okay, and also H for hydrolazine, and isoniazid prokinamide, okay, prokinamide. This is also seen with this kind of drugs. Okay, so these are the important points that you have to know about the specific drugs and their side effects and associated these conditions. Next, moving on to the rate limiting steps. So the important one, glycolysis. The rate limiting step is the phosphofructokinase. Next, another one is the gluconeogenesis. Fructose 1,6 bisphosphate, glycogen synthesis, glycogen synthase, glycogenolysis, glycogen phosphorylase, TCA cycle, isocyprate dehydrogenase, fatty acid synthesis, acetyl-CoA carboxylase, fatty acid beta oxidation, carnitine acyl transferase, cholesterol synthesis, HMG-CoA reductase, urea cycle, carbamyl phosphate synthetase, purine synthesis, glutamine, PRPP, amido transferase, pyrimidine synthesis, carbamyl phosphate synthase 2, and heme synthesis, ala synthase, pentose phosphate, G6PD, and ketogenesis, HMG-CoA synthase. See the difference? It is the reductase in the cholesterol, ketogenesis synthase, and de novo fatty acid, elongation fatty acid synthase. Fructose metabolism, aldolase B, and galactose is the galt gene, and glucose uptake in the muscle is the hexokinase. These rate limiting steps can also be in the asked in the examination. Next, moving on to the cytokines, histamine, which will be important for the mast cells, basophils, and the platelets. The most important function is here vascular permeability. And next, serotonin, it can act as a vascular permeability vasoconstriction. And platelet activating factor, it works as a vasoconstrictor, platelet aggregation, vascular permeability, bronchoconstriction. Nitric oxide, arginine derivative, it can cause the platelet aggregation also, it will decrease the platelet aggregation, vasodilation, smooth muscle relaxation. Coming to the cytokines, IL-1 is for the fever, IL-4 and 6 anti-inflammation, IL-5 for the eosinophils, IL-8 neutrophils, IL-10 and 13 TGF-beta anti-inflammatory, only TGF beta fibrosis, and vegetative here epithelial growth factor, angiogenesis, interferon alpha acute inflammation, and TNF alpha is also acute inflammation, and interferon gamma for the macrophage activation. Okay, next, moving on to the monoclonal antibodies. The importance of the monoclonal antibodies, we all know that this is going to mimic the whatever the drugs that is present. So we are making the lab so that this will act on that particular things. For example, let's see anti-TNF. Okay, anti-TNF alpha. So for this inhibitor, we have the drug infliximab. Okay, this is the drugs infliximab is present. Next, anti-CD20. So for this anti-CD20, rituximab. Okay, rituximab, pemphigus vulgaris, and also non-Hodgkin lymphoma, we are going to use this rituximab. Next, anti-HER2 gene. This anti-HER2 gene or the new gene, this is commonly used in the breast cancer patient, trastuzumab. Okay, trastuzumab drug. Next, anti-GFR. Here you have the anti-EGFR. So this is CETU, C and E. Okay, beside words, right? Almost this is the cetuximab. This is the one drug. Next, anti-VGF. Anti-VGF for the patients those who are having the macular degeneration or the retinal changes. This is ranibizumab, ranibizumab and bevacizumab. Okay, bevacizumab. Next, anti-IL-6, anti-IL-6. This is commonly used tocilizumab. This is tocilizumab used for the rheumatoid arthritis patient. Next, anti-IL-17. This is secukinumab. Anti-VGF, anti-IgE. Remember, this is the omalizumab. Omalizumab. Okay, and anti-eosinophils. Anti-eosinophils. This is duplizumab. Okay, duplizumab. Okay, these are the some of the drugs that you have to remember. And associated RS infections. So for the infection, for the RSV infection, we have the palivizumab. Palivizumab. For the COVID-19, commonly used drug tocilizumab. Okay, this is the high level drug. Next, Clostridium difficile. So for this one, we are going to use the bezlotusumab. Okay, bezlotusumab. Okay, these are the commonly used drugs for the patients, those who are suffering from the infections. Okay, these monoclonal antibodies that you have to remember, guys. Okay. And next, moving on to the dermatophytes. So dermatophytes, this structure is commonly asked in the examination. Okay. So the trichophyton will be looking like this. And here you can see this is the single pencil-like structure you will be seeing. And it will involve skin, hair, nails. And next, coming to the microsporum. And microsporum, this conidia, you are going to see the conidial structure, which will be look like this structure, like a boat like structure. You are going to see skin and hair will be included. Next, clusters kind of epidermophyton, skin and nails will be included. So again, another picture here you can see this is the microsporum and this is the trichophyton and this is the epidermophyton. Okay, next, moving on to the candida. So candida have the many kinds of the important things about the candida is you have to take note about that diagnostic test, how they are going to look like. On the KOH, Candida is going to produce the pseudo hyphae. Okay, it is going to produce the pseudo hyphae. Here you can see this is how the pseudo hyphae, this budding yeast which will be produced by the Candida on the KOH. Okay, next we also do the germ tube test. On the germ tube test, the Candida is going to be positive. Okay, Candida is positive. If it is negative, that is not a Candida species. Okay, this is the best rapid test for the Candida. Next, what is the culture that we use for the Candida? Sabrod dextrose agar. Sabrod dextrose agar we can use. And another agar is the chrome agar. Chrome agar can be also used and positive for the Candida. And especially on that, you are going to see the green color colonies. Okay, green color colonies which will be presented as a the Candida species. Next, cornmeal, cornmeal agar, cornmeal agar, which will be show the chlamydospores. Okay, chlamydospores of the Candida, which will be present. Next, another test that is the beta D glucan assay. Okay, beta D glucan assay, which is severe Candida, like invasive Candida, will be positive for this culture. Okay, these are the some types of the Candida test that you have to take note. Next, moving on to the injuries. So in the injuries part, you have to understand how the each and every injury will be presented. Okay, so here in the picture, here you can see, first of all, take note how other structures will be seen. What are these different structures that we have seen here in this patients? So this is abrasion, this is superficial abrasion, and this is laceration. Okay, and here incision. This one is the puncture wound, puncture wound. This is second degree burns, and here these are the pressure source. This is tear, and this one is the contusion. This one is known as a contusion. Let's see one by one what is the differences that you have to observe in this structures. Okay, so first, whenever you are seeing the abrasion, abrasion is going to involve the superficial structure. Okay, only the epidermis is going to be damaged in this particularly the abrasion. When it is comes to the abrasion, it is going to only involve the superficially partial epidermis only involved. So when you see the patient, those who are having the this condition abrasion, the common examples are pressure abrasion. Okay, pressure abrasion, which will be associated with the ligature, right? Ligature marks. Next one, imprint. Okay, next one, imprint abrasion or the impact abrasion, especially those who are having the accident RTA cases, that pressure abrasions or the impact abrasions you are going to see. Next, grazed abrasion. This grazed abrasion is also seen in the RTA patients. Okay, next, moving on to the laceration. So laceration can be deeper and the margins of the laceration will be irregular. Okay, this is going to have the irregular endings that will be seen in the laceration, and at the same time, whatever the present, the hair bulbs will be crushed. Okay, skin and the hair bulbs will be vessels also crushed in this person. Okay, so types are stretch ulcer, okay, split laceration, stretch laceration, and avulsion injuries. Okay, avulsion injuries. Next, incision. So incision will have the regular. Okay, incision will be having the regular clean margins. Okay, this will have the regular and the clean margins. And puncture wound, only the small pinpoint will be seen. Burns, just above we discussed. Pressure source, this is due to limited activity, and according to the grading, it can be subcutaneous also. Tear, this is due to friction, this is due to friction. Next, coming to the contusion. This is due to dermis involvement with the extravasation of the blood. Extravasation of vessels. So in this, you are going to see the battle sign, those who are having the fracture of the mid cranial fossa fracture. Okay, next, other one is the raccoon eyes seen in the anterior cranial fossa fracture. Okay, these are the some of the injuries that how to identify. Next, coming to the bullet wounds. So this wound is known as a contact shot. Okay, so this is the contact shot. So how can you understand this is the contact shot? Because there will be stellate shape will be seen. Okay, so this stellate shape will be seen with the contact wound. Okay, next, this bullet wound will also show the burning will be seen, and blackening is also seen, tattooing. Okay, these all features will be seen in the contact shot. Next, we also have the close shot. In the close shot, you are going to see only the blackening and tattooing will be seen. So this one also show the single mass. It is look like a single mass. Next, this is the near shot. Okay, in the near shot there will be tattooing. There will be tattooing only seen, and grease collar. A grease collar will be also seen. Grease collar is seen in everything, guys. Next, this is the distant shot. This is the distant shot. So in the distant shot, you are not going to see anything, and multiple petals. Okay, multiple petals will be seen. These marks. Okay, this multiple petal marks will be seen. Okay, along with that, grease collar will be also seen in this patient. So this is the contact, close, near, and intermediate and the distant shot. Okay, next. Here we completed important points of the injuries and the bullet injuries. Next, moving on to the biostats. So in the biostats, here you can see this is the important picture that is known as a standard deviation. Right? In the standard deviation, there are some important points that you have to take note. What is this shape? So the common shape of this one is the bell shape. Okay, bell shaped. So mean is equal to median, and median is equal to mode. This is how the normal standard deviation will be seen. So the plus one is 68%, plus 2 which will be 95%, plus 3 is around 99.7% of the accuracy that will be seen here. All right, next, here you can see the negative skewed, normal, and the positive skewed. In the negatively skewed, the mean is less than median, and median is less than mode. Okay, mode will be the highest in the negative. And again, so in the positive, mean is greater than median, and median is greater than mode. And next, coming to the different types of the charts, this is a bar chart, histogram, scatter plot, line chart, box plot, and the pie chart. Again, these are the line charts, bar charts, histograms, pictograms, and cubic graphs, scatter plots, pie charts, surface response charts, and contour plot charts. Okay, these are the different types of the graphs. Next, coming to the p-value. Okay, coming to the p-value. So p-value is normally between the range of 0 to 1. And how much is the normal value? 0.05 p-value is standard. Okay, if let's see, p-value is less than 0.05 and p-value is more than 0.05. Okay, if it is less than 0.05, this considered as a significant. This is considered as a significant, and null hypothesis will be rejected. Okay, but if it is more than 0 point, this is insignificant. This is considered as a insignificant, and null hypothesis, whatever we proposed, will be accepted. Okay, so next, coming to the test, different types of the test that we are going to perform. Right, the quantitative test and qualitative test. Right, qualitative test. So in the quantitative test, these are known as a parametric test, and these are non-parametric test. These are non-parametric test. So if you are only comparing one group, then here there is a paired t-test, paired t-test. If it is a two groups, then it is unpaired t-test, Unpaired t-test. If it is more than 3 groups, then it is ANOVA test. ANOVA test. And non-parametric tests are like different names. McNemer test, chi-square test. Okay, this is the chi-square test. And K Walker, sorry, K Waltz. Okay, this is the K Waltz test. Okay, these are the different types of the test that is present in the biostats. Next, moving on to the national programs. So here in this picture, you can see there are the different types of the programs that we are seeing. So this is known as a Janani Sishu Suraksha Karyakramam, right? Janani Sishu Suraksha Karyakramam. What we are going to do in this first maternal, so facilitating for the delivery and also newborn care. Both are included in this person. Next, Laksha, L for Laksha, L for labor. Okay, so labor room cleanliness, labor room cleanliness we are going to see. And this is Suman. So what is Suman? So it has to decrease the maternal and children mortality. That is the goal for the Suman program. Next, this is considered as a Navajat Sishu Suraksha Karyakramam. So we are going to give the training for the newborn care. Newborn care should be given for the healthcare workers. Healthcare workers. Okay. Next, Janani Suraksha Karyakramam. Here we are going to give the incentives for delivery in our PHC, in our CHC. We are going to give the incentives for the mother and also for the ASHA worker. Okay. Next, RBSK is going to consist of the D's. Okay. D for defect, delays, deficiencies and diseases. Okay. From what age? 0 to 18 years. RBSK. Okay. Rashtriya Bal Swastha Karyakramam. RKSK is going to only focus on the 10 to 19 years child. Okay. That is adolescents people that we are going to look after. Next, Suraksha Karyakramam. For the Suraksha clinic, for the patients, those who are suffering from the STD or the sex related problems. Okay. Next, NACO is for the HIV and AIDS. Next, moving on to the Pradhan Mantri Pradhan Mantri Matru Vandana Yojana. Here, the Pradhan Mantri scheme is going to give the 5,000 incentives, 5,000 incentives for the all the pregnancy women, for all the pregnancy women. Next, another picture here you can see Suraksha Matritva Yojana. Every month of the 9th, there will be antenatal visit that will be given for the mother. Okay. Next, this is the Anemia Mukt Bharat, which will be consisting of the 6 beneficiaries, 6 institutions, and 6 interventions. That is for the Anemia Mukt Bharat national programs. Next, some of the logos. This is for the TB Harega, Desh Jitega, and this is for the vaccination Mission Indradhanush, and this is for the patient's employee security insurance. This is the non-communicable diseases, HIV and hypertension. Sorry, only hypertension, diabetes mellitus, and non-communicable diseases. And this is for the vector-borne leprosy patients, ICDS, Anganwadi centers. Okay, Nick Shai, KS for the TB. Okay, KS for the TB, and SH. This is for the pregnancy kit. And here you can see this is the Vision Clinic logo, and this whole picture is for the hypertension. What is this consist? This one point is going to be the patient are adequately treated, and eighth, this one is going to be inadequately treated and but diagnosed but not treated, and patients who are diagnosed but untreated and diagnosed with the hypertension, undiagnosed with the hypertension, total hypertensive subjects, normotensive subjects, and whole community. Okay. Next, another types of the logos. World Health Organizations. Where is the headquarters? Geneva. And UNICEF for the maternal and child welfare. And again, leprosy. This is for the iodine. This is for the iodine and women and child development, vision and vector-borne and national health mission of anemia prophylaxis, pulse polio, and this is the DOTS program for the TB, World Bank and Ministry of the Health and the Family Welfare. This is for the Jandan Yojana for the incentives, ICDC program, and here completes and your humidities. Okay, this is difference of the air factors that you are going to check. So how you are going to check this one, guys? What is this small one that you are seeing here? This is known as a kata thermometer. Okay, this is kata thermometer. So importance of the kata thermometer, this is going to calculate the cooling power of the air. A cooling power. Next, this is known as a sling thermometer. This is for the humidity of the air. And this is anemometer for the velocity of the air. For the velocity of the air. Next, this is the globe thermometer for the radiant. This is work as a radiant. Next, Sapna is for the leprosy. Meena is for the child empowerment. Okay, child empowerment. Here, this is the copper teeth. This is the Antara, vaginal ring, diaphragm. Okay, cold chain is for the vaccination and occupation hazards. Leprosy day, that is the Jan 30th, vitamin A prophylaxis. This is the red collection bag, no smoking day on the 2nd March, and no tobacco day is the 31st May. Immunization program, universal health, AIDS control logo, and this is the national health insurance policy, immunization, herd immunity, and biohazard waste. Okay, these are some of the important logos that you have to take note. Next, coming to the antibodies. So the anti-post synaptic ACH is for the myasthenia gravis. Anti-presynaptic voltage gated calcium channels for the Lambert Eaton. Anti-beta 2 glycoprotein for the anti-phospholipid syndrome. ANA is for the non-specific SLE. Anti-cardiolipin lupus also again for the anti-APLA syndrome and also SLE. Anti-dsDNA, anti-Smith, SLE, anti-histone for the drug-induced lupus, anti-U1RNP, this is for the mixed connective tissue disorder, anti-CCP, more specific for the rheumatoid arthritis, anti-Ro and the anti-La for the Sjogren's, anti-SLE70 for the scleroderma, anti-centromere for the crust syndrome, anti-synthetase for the polymyositis, dermatomyositis, anti-mitochondrial for the primary biliary cholangitis, anti-smooth muscle for the autoimmune hepatitis, myeloperoxidase for the microscopic polyangiitis. Okay, and P anca. This is C anca. This is the C anca, guys. Granulomatous with the polyangiitis. Next, anti-hemidesmosomes, bullous pemphigoid, anti-desmoglein, pemphigus vulgaris, anti-thyroglobin, Hashimoto's, anti-TSH receptor, Graves' disease, IgA, and anti-tissue transglutaminase, celiac disease, anti-isolates, that is for the type 1 diabetes, anti-parietal cell, anti-intrinsic factor, pernicious anemia, anti-glomerular basement membrane, good pasture syndrome. Next, some of the immunodeficiency syndromes, severe combined immunodeficiency, which will be RAG mutation and anti-dismutase adenosine deaminase deficiency will be seen in this patient. Okay, they mostly T cell receptors will be decreased in this patient, and most commonly bacterial, fungal, and protozoal infections will be seen in this patient. Next, ataxia telangiectasia, this is associated with the defects in the ATM gene. Okay, and this patient cerebral effects, pyrangiomas, IgA deficiency seen. Next, hyper IgM, CD40L, and T helper cells will be defected. Next, Viscott Aldrich, this is associated with the VAS gene, and this patient will be having the thrombocytopenia, eczema, and recurrent infections will be seen in this patient. Next, coming to the leukocyte adhesion defect, this is associated with the LFA integrin defect, that is CD18. Okay, next coming to the Chidiac Hagashi syndrome, list gene. Okay, list gene, progressive neurodegeneration, lymphohistiocytosis, albinism, recurrent pyogenic infections, chronic granulomatous due to defect in the NADPH oxidase. So the patient is more susceptible to catalase positive enzymes, catalase positive organisms. Next, moving on to the amniotic fluid. Okay, in the amniotic fluid, you have to understand the common differences, how to differentiate, and what are the defects that we are going to see in this patient. So first, those who are coming from the amniotic fluid defects, oligohydramnios, this is less than 5 centimeters, or single pocket less than 2 centimeters. So the most common cause for this patient is the idiopathic cause. There will be idiopathic cause, and if it is most severe, then likely to be this is the renal effect. Okay, renal agenesis. and also those who are suffering from the hypertension, intrauterine growth restriction, and twins. Okay, twins different syndromes will be seen. Those who are taking the ACE inhibitors, and also those who are suffering from the post-term. Okay, post-term also seen. Next, coming to the polyhydramnios. This is also most commonly idiopathic, and GI anomalies. GI anomalies such as esophageal atresia. Again, twins, diabetes mellitus patient, Rh negative patient, and also those who are suffering from the hypertension also seen. Okay, these are the some of the causes for the oligohydramnios and polyhydramnios. Next, another thing that you have to take note that these patients have the specific colors also. The green color is commonly seen in the infections like listeria, or patient is IUGR with the fetal distress. Okay, next, gold color is seen in the Rh negative pregnancy. Brown color is seen in the intrauterine death. Dark color is seen in the abruptio placenta. Saffron Saffron is seen in the post-term individuals. Okay, in the post-term individual, you are going to see the soft color. Next, amniotic embolism. Okay, amniotic embolism. What is amniotic embolism, guys? So, amniotic embolism, this is the emergency situation. But how can we differentiate between the amniotic embolism? This is actually very rarely seen immediately after delivery. Okay, immediately after delivery, or it can be seen during the delivery also, we are going to see. And mostly why this has happened, it's still unknown only. This is also idiopathic cause. Idiopathic cause, it's kind of like going to cause the this amniotic emboli, which will be reaching to the pulmonary vasospasm and irreversible heart failure, and DIC will be seen in this patient. Okay, what is the symptoms? Sudden onset of respiratory distress, sudden dyspnea, hypoxia will be seen, and sudden BP fall, and also the patient will be having the oxygen fall, which will be seen, and DIC symptoms will be presented. Right, this is the how the patient will be altered sensorium, seizures, cyanosis, all that will be seen. Right, next, what is the treatment that you have to give? The management is the supportive management. So airway, breathing, circulation should be maintained for this patient. And to prevent the DIC, you have to give the fresh plasma, that is the transfusion should be done, cryoprecipitate, whatever that has to be done, because it is a very direct, immediately the death can also happen in this patient of the amniotic embolism. Next, moving on to the physiological changes. So when I say about the physiological changes, it is two types. One is related to the progesterone and other one is related to the estrogen. Okay, so the progesterone is going to first, it maintain pregnancy. It is going to maintain the pregnancy, decrease the peripheral vascular resistance, smooth muscle relaxation will be seen, and also it will prevent the preterms. It will prevent the preterms. Next, estrogen, which will be causing the chlasma changes, cholestasis. Okay, increase the TBG, thyroid blinding, globulin will be increased, oxytocin release, it will help. Okay, spider angiomas. These other changes like blood volume will be increased. Okay, so blood volume, if it is a blood volume increase, this is known as a hemodilution, guys. Okay, this period is hemodilution, increased RBC, increased hemoglobin content, increased globulins. This is C. What about the decreasing? Basically, the decreased platelets. This is condition is a benign condition. Decreased hematocrit. This is due to hemodilution, and decreased factor 8 and factor 11. Coming to the cardiovascular changes, S1, S2, along with that S3 is also seen, and this 3 is considered as a normal, and also early systolic murmur will also be present. This is also normal. Increased cardiac output and decreased peripheral vascular resistance. These are the cardiovascular changes that you are going to see. Next, coming to the different signs, Goodale sign is the earliest sign that we are going to see softening of the cervix. Okay, and this is around 6 weeks of the patient. Next, next one is the Chadwick or the Jack bluish discolorization. You are going to see this is around 6 to 8 weeks. You are going to see. Best to choose the 8 weeks. Next, Osiander sign, pulsation is felt on the lateral vaginal walls. Palmar sign, rhythmic uterine contractions felt around the bimanual examination. Pisces sign, asymmetrical uterine enlargement due to eccentric implantation. Hagar sign is the softening of the uterine isthmus felt during the bimanual examination. This is all also around the 6 to 10 weeks. Okay, this is how you can remember the important signs and the physiological changes. Next, coming to the semen analysis. In the semen analysis, according to the WHO, this is the normal values, guys. All these are considered as a normal value. Sperm value more than 1.5 ml is the normal. Sperm concentration more than 15 million. Total sperm count more than 39 million. Sperm progressive motility more than 32%. Sperm morphology more than 4%. Sperm DNA fragmentation less than 30. Non-sperm cells less than 1 million. You are going to see. Next, some student has been asked me the question how to differentiate different types of the X-rays. Okay, this condition is known as acute respiratory distress syndrome. So basically, this condition will be seen as a white out lung. Complete, you are going to see the white out lung. Why, guys? Because there is a surfactant damage that will be seen in this patient. Okay, the bilateral diffuse opacities will be seen. Diffuse opacities will be seen in this condition, right? Next, coming to the pleural effusion. Okay, in the pleural effusion, you are going to see this classical meniscus sign. Okay, meniscus sign you are going to see. Along with that, the costophrenic angles. So here there will be costophrenic angle, right? These costophrenic angles will be blunted. These costophrenic angles will be blunted. Okay, next, coming to the pneumonia. So the pneumonia will be consisting of this kind of consolidations. These are known as a consolidations or patchy infiltrates. Patchy infiltrates will be seen in this patient. Okay, this is how we are going to differentiate between the ERTs. This is the pleural effusion. This is the pleural effusion, and this is the pneumonia. These are the some of the important changes that you are going to notice. Next, congenital infections. So in the congenital infections, there will be a important traits that you have to take note, guys. First, this is the picture of the patient suffering from the toxoplasmosis. So in the patient's toxoplasmosis, there will be intracranial calcifications. Here you can see these are the calcifications and also hydrocephalus, chorioretinitis. Chorioretinitis will be also seen in this patient. Next, CMV. This is the cytomegalovirus. You are going to observe periventricular. This is the ventricles, right? So here you can see these are the calcification. Periventricular calcifications. And patient will be having the condition of the glaucoma and sensory neural hearing loss. Next, this is the rubella. In the rubella, you are going to see the leukomalacia. Leukomalacia. Along with that, cataract, congenital cataract, patent ductus arteriosus, sensory neural hearing loss. This is Zika virus. This patient is Zika virus. There will be microcephaly. Microcephaly will be seen and atrophy of the cerebrum and contractures. Patient will be having the CNS seizures that will be seen. Okay, next, congenital syphilis. So in the congenital syphilis, so there will be no changes in the patients of the CNS changes, but congenital syphilis patient will be having the symptoms such as sensory neural hearing loss, along with that Hutchinson teeth, and also okay rhinorrhea will be also seen in this patient. Okay, this is the how the patient will be suffering from the transplacental transmission. Okay, this is the one thing that you have to remember for the syphilis patient. Okay, this is actually known as a snuffles. This is known as a snuffles is seen in this patient. Okay, next, moving on to the important topic, congenital heart diseases. Okay, by the pictures here you can see these congenital diseases. Here you can see the first one is the tetralogy of the phalate, and this is the Epstein's anomaly. This is the condition of the Epstein's anomaly. This is partial anomalies of the pulmonary veins. Okay, this is the partial anomalies vein. Next, this is the transposition of the great arteries. It is total anomalies pulmonary veins, and this condition coarctation of the aorta. These are the important X-rays that you have seen. Next, other than that, you also have to know about the important points of the different types of the conditions. Okay, different types of the conditions that you have to take note. Let's see one by one. What are the cyanotic? What are the acyanotic? So, in the acyanotic, the most common is the AST. In that, ostium secundum is the most common, right? In the ostium primum, which will be seen in the patients of the Down syndrome. This is the most common. Next, coming to the cyanotic, the most common is the tetralogy of Fallot. Tetralogy of the Fallot is the most common. And tetralogy of Fallot have the specific features, guys. What are the specific features of the tetralogy of Fallot? You are going to see the patient will be having the overriding of overriding aorta, along with that right ventricular hypertrophy, pulmonary stenosis, subpulmonary stenosis, or we can also add the ventricular septal defect. These are the tetralogy of Fallot signs. Okay. Next, coming to the VST. In the VST, the most common type is the perimembranous. The perimembranous type of the VST is most common, and it will be consisting of the pansystolic murmur. Pansystolic murmur. Okay. Next, patent ductus arteriosus. This is seen with the patients of the preterm condition, and this is associated with the continuous missionary murmur. This is associated with the continuous missionary murmur you are going to hear. Next, we all know that PDA can be given drug of the choice. So here you are going to use the ibuprofen. Ibuprofen is the best drug so that it will decrease the prostaglandin. Okay, it will decrease the prostaglandin. Epstein's anomaly associated with the lithium exposure in the patient. The Epstein anomaly is associated with the lithium exposure, and also this will cause the increased arrhythmias risk when they are born, associated with the increased arrhythmias. Next, the total anomalies parenteral and partial anomalies dagger sign. Coarctation of aorta associated with the Turner syndrome. Right? These are the important points that you have to take note of these conditions. Okay. Right. So here we wrap up the all important topics, guys. If you have watched the rapid revision programs in my channel and this important short topics, yes, you are good to go to the examination. At least 200 questions with your practice of the MCQs and your hard work, you are going to clear this examination. All the best, guys. All of you, please give your examination very best. Don't stress much. Be active, be confident, and whatever you have read, whatever the hard work you did, it's really great, and you have to achieve this examination with a great score. Okay, so until then, please be confident and spend the good time with your loved ones, and also give your best in the examination. All the best, and see you all on the results day, and continue to preparation until the exam day, guys. Take rest and take care of yourself. So those who are new to this channel, please do subscribe and share with your friends. Bye everyone.